efficacious and what is working in patients, with patients, payers, providers, life science companies, employers, and investors. And so my name is Stan Kishnowski. I chair HITLAB, and we're very excited to have a full program for you today. And we're going to kick off with Vlad Neste from Nagarro, one of the world's leading digital health and IT solutions companies, the global firm, talking about closing the gaps in digital implementation. Nagarro is one of the leaders in being able to help implement digital health technologies in payer, provider, and pharma. Then we're going to have a second hour and a third hour of lots of activity going on with bioinformatics in hour number two, not only from Indigenous, but also with several other very interesting companies. And then in the third hour, we're going to be talking about heart disease and algorithms as we talk to Moin Husani from AcuCardia, one of the leading AI companies these days who are taking EKGs and helping physicians diagnose patients with heart disease from very nuanced data and being able to pick that up. And then we'll be finishing off the third hour with Leslie Godkin from Home Catalyst, an innovative, revolutionary platform for people who are working with older adults and with any kind of developmental delays or disabilities, and providing homes and solutions for them in their communities. So that is the schedule. We are really excited to have you all with us here today, and we are going to kick off with Vlad Neste from Nagarro. Vlad, thanks for joining us today.
Hello, everyone. Thank you, Stan, and thank you for organizing.
And if you could, let's start off with just a little bit about yourself and what you do at Nagarro.
Yeah, for sure. My name is Vlad. I'm coming from Eastern Europe, from the famous land of vampires, Transylvania. I moved to New York in October last year, and I'm leading the business development of Nagarro Life Science and Healthcare globally. Nagarro, as Stan, you mentioned, is a global company, probably the company that you never heard about, but we are behind a lot of products globally. If you flew with Lufthansa, the software which is running on them, it's built by Nagarro. If you ever look at the White House and Statue of Liberty, the software which is creating the lightning is built by Nagarro. If you do your test blood, probably you get into connection with one of the devices that is running a software from Nagarro globally. We don't have products, so all the IP stays with our customers, but we are behind quite of some very interesting products and innovative. Thank you for having me.
No, it's fantastic, and really appreciate your time today. I know how busy you guys are and are appreciating everything you're doing within the ecosystem. And again, with offices in New York City and around the world, it's great to have you in the ecosystem and good to see you. And I know we'll be seeing a lot of you next week at the summit as well. And certainly people are going to want to know a lot about your implementations and how things are going when you're implementing. But if you could, you guys do a lot of work across the ecosystem, payer, provider, pharma. Talk to us a little bit about the most pressing gaps that you're seeing in population health infrastructure and where the biggest opportunities are for people to scale high impact digital solutions across these major stakeholders.
For sure. Since I moved to US and I was paying a lot of attention on US market even before, there are some numbers that are keep coming back to me, right? If you look in Chicago, the life expectancy varies by up to 30 years between neighborhoods, which are just few miles apart. If you look at New York or Washington, it's around 27 years. And that's NYU data from CDC data that it's analyzed. So where you live actually predicts how long you live, more reliable than blood pressure or genome, right? And that's striking. Another part which is striking, it's that's not a knowledge gap, right? We know this for decades. We have the data for a long period of time, CDC, Medicaid, hospital discharge. We all have the data. So communities are not under measure, they're, I think, over measured. And what's missing, in my point of view, is the integration layer on top of the data, the things that actually collects the signal and turns them into decision someone actually can act on it. Most public health departments already have, based on our experience, already have warehouses, right, that collects the data and integrates. They even have very beautiful dashboards that already implemented. The only problem is that nobody's actually using them. Nobody's actually looking at them and taking action. So the biggest scale opportunity isn't more data. It's building that aggregation layer that I was mentioning on top of the data that communities already have.
Yeah, I could see that. And we see that every day, really, across the United States. And when you take a look at digital transformation, a lot of people are debating whether it's going to be a gap widener in terms of the digital divide, or it's going to reduce a lot of the gap in the digital divide. What are you seeing in terms of using digital as a transformational tool, as well as data interoperability? I think data is a big piece of this
Right.
in a way to support public health systems and to address these kinds of disparities in advancing health equity.
Yeah, the time is now, right? So FHIR is real. Patient records are standardized with a very fast pace. There is this initiative of OHDSI, which have more than, I think, 900 million across 74 or 64 countries on a common data model. So the data exists there. CMS has shortened standard prior authorization this year, beginning of this year, from 40 days to 7 days. So the infrastructure that we have now, and we see that it's developing right now, unlock things that we couldn't have saw it 5 years ago. But here where I'm very careful, right? Interoperability doesn't necessarily mean equity. If we connect the system that we already have without changing who decides what gets where and how they're interpreted, we will just have better pipes for the same biased output. So basically, we will have digitalized the inequity. Last week, I was in Stanford, and they presented a very interesting report. It's built by Stanford Digital Economic Lab. They looked over 51 enterprise AI deployments. Now we have AI fatigue, but they analyzed very, very interesting what's happening with this 51. Of course, it has a bias because they're only successful, but the data is quite impressive. So they found out that more than 77% of the hardest challenge of implementing AI solution were invisible solutions. So change management, data quality, process redesign. So not the technology. The technology is there yet. The difference between deployments that work in weeks and those that failed after years was never the model. It was always the organization and how they handle this transformation. The equity questions question that you put for interoperability is not is the same question, right? Not can we connect it, but who's accountable for what we are connecting and what we are producing.
I love it. And that's what really it matters the most is how we are able to bring this together and make it work. And have you seen specific strategies working for people who are trying to align their digital health innovation strategy with the community needs? And if so, what are you seeing that's working right now?
Hmm. I will get even a little bit more specific because the pattern that we see working across the engagement at Nagaro, in cancer centers, in integrated delivery network, in life science, in medical devices company, they have one thing in common. None of them is actually a data project. Everyone is a workflow project, right? They sit on top of data for a couple of years, organization data, and they are trying to make it the solution, trying to make it work with that data, right? The same Stanford team mentioned, found out that something striking that I was not expecting. Actually, two things. One is, and for healthcare companies, one that the data is not a problem. Secondly, they gave us a very interesting case study that I will not mention the name of the hospital, but physicians adopted ambient AI transcript, right? tool without actually a formal approval. And the reason why, because the burnout was so acute that the formal procurement process was so slow that they didn't want to wait. They just implemented. And to be honest, that's not a technology success story. Rather, that's a workflow failure that technology was there just to help them. So my first strategy is a little bit humbling, I would say. My recommendation is sit, and that's what we do at Nagaro very often. Sit with the community leaders, with the case managers, with the ED nurses, at least week before starting to write any specification or giving now to an agent to write specification to find out what actually the workflow it is. So build for workflow, not for the workflows that we imagine or we desire that we would have in the community. And secondly, and maybe that's also a test or recommendation to the audience, when a vendor walks in selling new data, ask why your existing data is not already enough, right? And if they are selling a platform, put similar questions. What decision will support that platform and what will change in the future? If they cannot answer in 5 minutes, then the gap will still be there even if you buy the data, if you implement a new platform.
Yeah, that's exactly correct. And it really is platform based. And thinking about that now, when you look at payers, providers, employers, pharma, what role do they play in terms of making sure that these solutions can be accessible by everybody in the community?
Yeah, good question. Private sector is, if we talk about private sector, right? Private sector is not going to solve health equity, right? Equity is a public good. It needs public will, it needs public funding, public infrastructure. What private sector can do and is doing is execute. Most digital health failures aren't failures of intent, they are failures of execution. Pilots that don't scale, platforms that don't integrate, and so on and so forth. Tools designed in San Francisco, in the Bay Area, and deployed in different regions without actually getting that insight on the landscape. Cultural responsiveness isn't a feature that you bold at the end. It comes from co-designing, from knowing the difference between a clinic that has mobile devices for all the nurses and then all of the doctors, or they have the bring your own device methodology, and hospitals that actually Wi-Fi drops at 3 p.m. That's an insight. And we saw it in our project that sometimes those insights came very late in the development phase. So I think the private sector earns the seat at the table when it does three things. It builds for the workflow that exists, not for the one that we imagine. It pairs every algorithm and every implementation with accountable owners on the ground, and it stops confusing scale with reach. And this is, I like to repeat this one: scale and reach. A platform that touches 1 million of people without changing anything for any of them isn't scale; it's just reach.
That's exactly right. Now we've got one more question, or time for one more
Right.
question. Could talk to us a little bit about the perspectives from the people you've worked with in hospitals and health plans and life science companies, and share a little bit with the audience who are watching from around the world about where you think the HITLAB community should be prioritizing implementations and digital transformation efforts.
Mhm. I started with an example and then I come back to your question. So what I see in the industry, right, and what we see, there are a couple of players which are understood that this creating the data layer, integrating with society, actually prove it's working and has a lot of benefit. Mayo Clinic is one of them. They created this clinical data network distribution that connects health data, plans, devices, and now they're planning to add even more. Hopkins with Precision Health platform. Also Columbia University. So there are a lot of movement into that part. I think getting now to your question, where we should invest is actually, because now technology is becoming, and AI is more a commodity, right? AI is so good, and it's still cheap nowadays that actually can do a good work. Where we need to focus in actually understanding the problems that are, let's say, on the shop floor, right? In the industry, in our neighborhood. Finding those problems and understanding what solutions we can implement. I think that's most important and crucial from now on, because again, technology from a price perspective and also from technology level, it's there. So we can leverage that one.
Fantastic. Again, Vlad, thank you so much for joining us today. Looking forward to seeing
Thank
you at the
you.
summit
See you
next
next
week.
week.
And again, for our attendees, for folks that are watching today, don't forget to sign up to attend the summit, to speak at the summit. We'd love to hear your ideas and your evidence of digital technology adoption in healthcare delivery and life sciences. Thanks, Vlad, for joining us today.
Thank you.
And we've got a full first hour coming up here. Next up is Giancarlo Palillo from Watch Your Own. I think we're very excited to have Giancarlo join us and talk about Watch Our Own. HITLAB did a validation study on the platform, and we're looking forward to having that data presented next week at the summit. But in the meantime, let's dive into it with Giancarlo. And if you could start out, tell us a little bit about your background and your journey to starting up such an impactful platform like Watch Our Own.
Sure. Glad to see you again, Stan. But yeah, my background is not in health when I first started. My background is essentially almost 40 years in technology, building predictive analysis engines for police departments back in 1988, banking systems in 96, all the way through from small banking systems to Bank of America, fleet mergers, Vonage technology groups, and then a lot of startups. I became a caregiver. I was in New York, CTO, living in New Jersey, Mount Pennsylvania, and that's where I realized that there's nothing there a decade ago that I could really trust. Having a PCI strong background in police environments and with RBAC roles and all those pieces, that I could actually trust using this, and needed everything to be in one. The data, the coordination, the real-time events, all of it. So that's what a bunch of people, primarily my wife, convinced me to build this Watch Our Own, and that's where we got off.
It's fantastic. And, let's dive into that a little bit further as well, because today we're really focused on community-driven approaches and how digital technologies and the adoption of digital technologies can help improve population health at the community level. And when you look at that, how can community-driven approaches help improve health outcomes compared to more traditional healthcare models that don't have a community-centric focus and don't have digital?
It's become a real problem. Being a computer scientist and a mathematician, my first thing I did was attack the data. What's going on? What's going to happen? This is going back into 2017, and you can see the trend. And so what we really need is a paradigm shift, going from reactive to proactive monitoring. And to do that, you have to tackle a $1 trillion issue that everybody's facing right now. And the way to do that is to do things like shifting to the formula by doing early prevention, creating a virtual circle of people that you trust. It doesn't have to be family. It can be family, it could be friends. It's just people that you trust, and that person trusts. And then giving them the tools to be able to monitor themselves, reduce hospitalization through medicine medication. It's not a hardware solution. It's a social engineering solution with real-time communications, updates, event tracking systems. And so if you compare the model to traditional, and you look at things like primary goals. In the traditional model, you're going to have treatment of acute illness, where in the community model, it's just prevention and the all-around well-being. Then you get into response types, and the response types, you're going to look at reactive in the traditional versus proactive, monitoring daily triggers, how's mom doing, communications about mom. Now, the key actors in the traditional will be the doctors, nurses, institutions. But when you look at from the holistic approach, then your family, friends, local caregivers, that trusted group of folks. As I mentioned to a talk I was in yesterday, in my wife's case, would have been Mickey, her mom, but it would have been her best friend next door, Carol, with and Jesse, these are groups, the people that she wants to see herself in. It's going to elevate her health being around those people. And then you get into communication where it's not a hierarchical approach. It's more horizontal real-time communication, distribution of data. And then the focus on the clinical systems versus a social determination and the daily lifestyle of that person. So that's what we're focusing on.
That is a great focus to have. And I think when we start looking at what's happening, especially in some of the deeper pockets of urban America and some of the areas of like rural America, we're seeing a need for transformation. But a lot of that transformation has substantial barriers for patients to access very, very basic healthcare services. From your standpoint and from what you've seen, not just in urban and suburban healthcare, but rural healthcare, what are some of those biggest barriers for people to access those kinds of resources that you're talking about?
100%. And I would add on, it's not just a United States issue, this is a global issue. I speak with folks all around the world, and that's why HITLAB is so important. It's something that's happening everywhere. Population explosion, longevity issues, and then you get into the barriers. And when you get into barriers, you're going to have models where you're dealing with the natural network, right? Where you're empowering a family and friends. It doesn't require, so let's get back to a comparison model again. I think it's probably the easiest way to go about doing this instead of getting too much into the details. So if you look at from a traditional response system, you look at financial burden, it's going to be professional home care nursing, and there's a limit to what you can do. Data privacy concerns, right? You're going to have data used for insurance and it's used for research. A lot of the undeserved population are very perceptive about the fact that they don't know where the data is being consumed, who's using it. And then you have the institutional trust issue, where you have a top-down clinical instructions and the fragmented care, which comes into a siloed Medicare facility. So compare that to where we're talking to you, exactly to your point, financial burdens. Now you're doing more of a coordination of natural caregivers. Who are your friends and family? You look at veterans. Who do veterans trust? Veterans. You can't talk to somebody who's been in active duty that's going to understand the civilian, is going to be able to communicate, but let them build their own group, the holistic group that they can trust, that they can share, they can watch out for each other. If you look at data privacy concerns, the same thing. We don't sell data. This is actually really important. We will never sell your data or share it. That's your data. You control that. Our vault guarantees that. There's no such thing as a perfect cybersecurity solution, but we're always constantly changing and having come from a police background and banking systems with PCI strong compliance, we're managing multi-million, credit cards. I look at the EPHI model the same way. Then you have institutional trust, where it's really bottom-up, community level-based advocacy and support, not what we were saying before, top-down. And the fragmented care issue, as we mentioned before, siloed medical care records as opposed to centralized real-time data sharing. So imagine we're in a situation where you're putting all your information into this vault, but this vault has to be FHIR. It has to have immutable logs. It has to have ability for me to redact EPHI data so I can actually use it for AI insights. Those AI insights are pushed back into the data stream again, so it can continue the model and see, and the user can see this. The user can actually leverage this without any fear because they control that data. They know that data is theirs.
That's exactly right. And so let's double click on that for a minute too, because I think, everyone wants to know how technology is playing a role to help these communities empower themselves, empower their patients and the individuals. How are they doing that?
Well, my tackle was that if I'm building this correctly, and from a again tech stack up, looking at it from a data architecture and cybersecurity models, how would I do this? You have to have role-based access controls. You have to have very strong access control layers for who can see what, when, where, and why. Just because you're part of a holistic group does not mean that you need to share your own personal information for people who are there to assist. What's the focus that we're trying to help? So we create the whole care narrative in the way that we're looking at from a virtual circle. The app allows the user to assemble this care group, and inside that you generate your roles. They're primary caregivers that could pretty much perform everything that the person needs done, create all the tasks, delegate efforts to other people, but also control who can do what with that care recipient and the connections that you can leverage. But once again, I'm going to push this back to the comparison model. So in a traditional approach, you have you're isolated. One person carries everything. That's what happened to me. You're the caregiver. I was already that it was a guy doing it. Most of these women are doing it. And when it happens, the family says, it's okay. Giancarlo has it. If he needs me, he'll call me. Giancarlo can't do it. Giancarlo's running around like a headless chicken. And when I looked at what's out there, I would have to get 4 or 5 different applications, ask everybody to join. They might have to pay for their own services and then try to somehow coordinate this. It has to be centralized. So it has to be collaborative. And in that case, it has to be responsive. It has to be a way to share and delegate this all across the group. Even if one person cancels at the last minute, how do you receive this real-time notification and see if you can delegate it to somebody else or take that on yourself? But you still carry on with your life. So reduce the pressure to the sandwich generation. Then you have the manual. If we go back to the standard process, everything's manual. What do you have in memory? What are you walking around with in a notebook? What do you do? What are you doing? As opposed to just having an automated, real-time triggers. Hey, you accepted this task to take mom to the doctor, and now it's live. The moment you click on the now, it's active. Everybody can see that you're en route. They can see where you are. If you enter the geofence, it closes the task. It lets the person who requested you to do the task that you're there. But if you're not there, what happens then? If they mark it critical, it goes into our Manager, which is a patented 911 system for families. So it's a family emergency response system for the way I would build one for a police, but I want to build it for the family and provide that solution for them. So it's a centralized, unified dashboard for the family to be able to take care of them. And again, I use the word family, but let's face it, women are living men. They have their own groups. They can generate their own virtual circle, just like anybody from this being the armed forces will decide to do their own. And again, it's about empowering the GPS and tools and services that we already have the devices. There's no additional reason why you have to buy something else. Just leverage everything that you have, so we can use as many features as possible. If you have a watch, we can track your vitals. Now we're doing threshold monitoring for those vitals. It only goes to primary caregivers and so forth.
That's amazing. So look, we've got about 3 or 4 days till New York City Health Innovation Week kicks off on Sunday afternoon at Yankee Stadium, and then going throughout the entire week. Almost 100 events, 10,000 people coming in, and we're going to have the HITLAB Summit as one of the foundation events at the Microsoft Tech Center in Times Square. You're going to be there, and I'm sure a lot of people that are joining us here today are going to look forward to seeing you. Tell me a little bit about what you're looking forward to seeing next week at the HITLAB Summit, and what you're looking forward to who you're looking forward to meet there.
Honestly, it's this whole experience with HITLAB has been amazing. Where you guys have put in place this I've been trying to get our services out there, and until we met last year, it just never really came around. And this has opened up a great door. So I'm open to sharing, talking to people in the investment group, and more importantly, the payers, because what we're targeting is the insurance health providers that are going to save money by using this. We're targeting the employee benefit programs, because losing $33 billion a year. When like myself, I left as a CTO, my entire IT group decided to leave. Then you have Medicare and Medicaid. So we've already had a meeting with one of the states and Medicaid, and their biggest issue is fraud prevention. So we have a whole rollout for fraud detection on any test that you could create, so they can see exactly when somebody marks something. So we want to talk to these payer providers. We want to be able to talk to them as well as the people who actually use this. And right now that's where we're thriving on. We're getting a lot of the feedback that we're creating new features, and we're going to continue doing this until we get it everywhere.
Well, looking forward to seeing you next week. Thank you again for joining us today, and hang on tight for a very exciting HITLAB Summit next week. Take good care.
Thank you, sir.
So that is, again, one of the thought leaders that are in the ecosystem around making sure that folks are really thinking about community-driven health and making sure that innovation and access equals empowerment. Next up, we're going to continue the conversation around this idea, this notion, and this work that the HITLAB ecosystem is focused on, which is really around population health and how to make sure that we're protecting everybody in the ecosystem. And helping us with that conversation is Lillian. She's an adjunct professor from Bowie State University. Lillian, thanks for joining us today.
Thank you very much for having me.
No, great to have you, and looking forward to hearing what you have to say. You're going to be doing a presentation, and we'll hand the virtual microphone over to you.
Great. Thank you all for joining me today. I'm really excited to be here. Today, I want to talk to us about trafficking as a public health issue, and my mouse comes on. Okay, great. And for our time together, I'm going to give us a little bit of background on what is human trafficking. Reframing the trafficking problem explains to us the importance of population health and data, human trafficking data, a population health response, lessons learned of a project that I implemented, and our call to action for us here today. So when we talk about human trafficking here in the United States, we use the legal definition for the Trafficking Victim Protections Act of 2000, which says that the use of force, fraud, or coercion to compel a person into commercial sex or labor, or any commercial sex act involving a minor. And what that means is that once a minor is involved, you don't have to show force, fraud, or coercion. Otherwise, you have to show that force, fraud, or coercion has been used to compel a person to commercial sex or labor. In the United States, we basically talk about sex and labor trafficking. However, globally, there are other components of trafficking, including forced marriage and organ trafficking. And recent data shows that there are about 50 million people in modern-day slavery across the world. Why do people go into trafficking? It's a profitable business, quote and unquote. 236 billion in legal profit is what people make in trafficking. Now, I'm talking about reframing the problem. The standard perspective, if you talk to somebody, 236 billion, that's a lot of money. And so people say that this is a crime problem. And we've tried to arrest our way out of it, that this is a law enforcement issue. There's also the stranger danger narrative. You may have heard about the white vans at the mall and things like that. It's like, oh, somebody's kidnapping somebody, and it's an individual who's making poor choices. When I looked at the data from the National Human Trafficking Hotline, however, we're seeing that there's a role for social determinant of health in vulnerability. Trafficking actually doesn't happen in a vacuum. Traffickers target vulnerable people, and because of that, this project looked and said that trafficking is preventable. And while I was at Polaris Project, I implemented an upstream prevention initiative looking at how do we save people at the population level from being trafficking victims. The human trafficking data that we have in the United States is data from the National Human Trafficking Hotline. The hotline used to be managed by Polaris Project, and I worked with them at that time, and now is managed by Compass Connections. Right now, they tell us that all-time statistics from 2007, when the hotline was beginning to operate, that they've received over 460,000 signals. Those 460 over those cases translated to over 100,000 cases with over 200,000 victims. Now you see that the cases don't exactly match to the victim, because one case might be on a farm, one farm might have 20 victims, or one trafficker, one pimp might have 10 people under their control. So the cases don't actually match to the victims. These numbers, as good as they are, don't really give us a true prevalence of what's going on trafficking in the country, because in order for somebody to call the hotline, they have to know that the hotline exists and they have to be able to call. So not everybody is able to do so. Some people who have the information and can call don't call the system because of distrust. Maybe they are worried about their immigration status or things like that. And even the people who call, sometimes they're in crisis situation. And because they're in crisis situation, you can't quite collect all the data. Remember, we have to establish force, fraud, and coercion if they are not minors. And so that's why you see that the signals don't automatically translate to cases, because somebody might call but not have enough time to give all the information about force, fraud, and coercion. We don't classify that case to be a trafficking case. But what happened in the year 2020 was that we looked at the data from the National Human Trafficking Hotline and really saw a disproportional representation of a particular group of people. People facing housing instability, poverty, people who have exited the foster care system, LGBTQIA plus people. And at that time, I implemented a safety net expansion initiative, which theory of change was that, look, if we're able to expand and strengthen the social safety nets for the most vulnerable community members, population, then we can reduce the conditions that make trafficking possible. This was a project I implemented in 9 cities across the US, involving 270 plus stakeholders, 36 survivor leaders, and social service organizations. What did this work look like at the city intervention level? These are some of the cities I worked in. In Louisville, some of the issues that bubbled up to the surface was for housing for youth and families with at-risk youth. So when a youth person has a juvenile record and that record is not expunged, when rental policies say that, you have to bring all of these documentations that young people don't have, when landlords or families don't understand that just because somebody is 18 doesn't mean that you have to turn them out, but the family is thinking that this person is 18, their income is going to begin to count in my income, I'm not going to be eligible in the house to keep this subsidized housing, then they're turning out young people to the population. Now, when this young person becomes homeless, this is the modus operandi of traffickers. They never come and say, I'm going to traffic you. They come and pose as a benefactor and they say, oh, you can come and hang out with me. Except after hanging out with the person 1 week, 2 weeks, 3 weeks down the line, you're being told that you need to do something to be part of the household and you end up in a trafficking situation. So for Louisville, it was like, what do we do for young people to make sure that they can stay in the house or they're ready and they can rent homes on their own without requiring documents that they don't have? In San Diego, what bubbled up to the surface was a safer space for LGBTQIA2 plus people. Now, it turned out that even though everybody says San Diego is a mecca for gay people, there's a Black population who said, look, the safety is only for certain people. So when we talk about health equity, should all people not feel safe if we say some place is safe for them? And why is a safe space important for the LGBTQIA plus people? It's not just for structure. One of the participants said, it's because being in some place provides support, social bond, and serves as an extended family. So when they don't have that place to go to find somebody that's an extended family, again, this trafficker is lurking in the wings and poses as this extended family, takes them in, you can come and hang out here, and they end up in a trafficking situation. Philadelphia was an interesting one because when we went to Philadelphia and spoke to the people said, we need a youth dropping center. And as we were having that conversation, somebody came and said, hey, you're talking about a youth dropping center. I have one. And so it's like, okay, you have a youth dropping center. Why are your community members saying they need a youth dropping center? Come to find out that location was key. If you want a youth dropping center, and why is a youth dropping center important as an anti-trafficking strategy? Because when there are young people who can immediately go home, either the parents are not at home, they can't go home, or there are no after-school programs for them to go, and they're hanging out just at the mall or in the neighborhood, guess what? Yes, the trafficker sees them, notices them, and says, you can come and hang out with me. And they might hang out scot-free the first couple of days, but then later on, they're beginning to be trafficked. Before they go home, they've already been trafficked. So that's why a youth dropping center was needed. Come to find out that it's not just to have a youth dropping center by name only. You have to have it at a location that people can access. You have to be providing services for them. If they want to have a shower, they want to eat, they want to be able to do their homework. What are all of those services and how are you providing those services for them? Other places that we worked was the establishing of a Survivor Advisory Council, and this was done in Dallas. Survivors need to be at the table because they have the lived experience to tell us what does trafficking look like. the stranger danger story is really not what trafficking is about. So for 6 months, we worked with a survivor consultant and a lead survivor to establish bylaws, to establish terms of engagement. How do you bring survivors to the table? And how do you make sure that survivors are equipped to engage the public or other partners? In Minnesota and Boston, we looked at the intersection of substance use and human trafficking. Traffickers, especially in sex trafficking, use substance use as a method of control. They either use it to lure people into trafficking or use it to keep people into trafficking. So if you are a substance use provider and you're treating somebody who is with a trafficker as an outpatient, how does that work? You treat the person and you release them to go and be with a trafficker that needs them to be on substance. And then you think that they are not complying with the program, but that's because you're releasing them to go and be with the trafficker. Or if you are law enforcement and you go out and you're arresting somebody for selling drugs, but that person is selling drugs because the trafficker has put them on the street. Can we connect them to service providers? And this was what the conversation in Boston and Minneapolis was about. It's like, so we had at the table the Boston Public Health Commission, the Massachusetts General Hospital, and service providers to say, how can we work with law enforcement to make sure that when we're picking people up, we are connecting them to services? 4 lessons, a lot of lessons, but 4 key lessons that we can benefit is cross. When we're talking about complex systems, we require cross-sector collaboration. I invited some people to the table, and at first they were like, oh, we don't work in the trafficking sector. I'm like, I know. And that's exactly why I'm inviting you to the table. Because if you provide immigration services and there are gaps in your services that you're providing, the trafficker is going to step up, not to be a trafficker from the get-go, but to meet that service. So we need to bring everybody to say, how are you doing? Because when you don't supply that need for the population, somebody is going to fall through the crack and become a trafficking victim. We have to move beyond, when we talk about cultural competency, we have to move beyond direct language translation. We created a Spanish language video for our population in Louisville, and it wasn't a start today and finish tomorrow, because it wasn't just translating the material literally. When you look at cultural competency and we talk with the people and let them know in nuances in the language, so that how does it resonate with the population? Now, data will open access, but trust closes them. When you see the data we went to all these communities with was that this data says that sex trafficking is happening in your community. But what really kept us in there was allowing the community to say, what does vulnerability look like in your particular community? And so you saw different communities chose different things. Somebody said it's youth housing, somebody said it's youth dropping center, somebody said it's LGBTQIA+, somebody said it's substance use. Let them say what is going to happen. You have the data to say this is what crisis looks like in your area, but have the community determine what it looks like. And survivor leadership is non-negotiable in these conversations. So what's our call to action out here? For data professionals, let's add trafficking indicators. Your community health needs assessment, a lot of people are collecting, doesn't have trafficking needs. So if somebody is leaving the foster care system, are they losing housing? What happens when they come in to check in their housing? What are you doing with that? Let health equity practitioners, let's explicitly name trafficking. People think that in order for me to be trafficked, I have to be a stranger, but you can be in your house. People are being trafficked by their parents, by their colleagues, by their workers, by people that they know. If we don't name this explicitly, then people don't know that there's a crisis. And for all of us, let's go out and look. I go to my healthcare provider. I get asked if I feel safe. So we're screening for domestic violence. How about we screen for human trafficking and at these opportunities? Let's have these conversations. Let's know there's more than stranger further danger in this conversation. I have a list of resources there if anybody wants to screenshot that, and I really thank you for the opportunity to share this important information about how human trafficking data lets us know vulnerability in our communities and what we can do to help people be safe. Thank you.
This is fantastic, Lillian. No, we really owe you a huge amount of thanks and gratitude for taking up this cause and really making sure that everyone knows what's going on and making sure that the alarm bells are being rung and the flares are being sent out because, again, HITLAB, I mean, you're very familiar with our work. We're very concerned about vulnerable populations, and whether it's pediatrics or geriatrics or new moms or anyone with mental health or whatever, these populations that you're studying and that you're researching and that you're helping are some of the most vulnerable populations in the world. So thank you for doing this great work, and we applaud everything you're doing. Please do keep it up, and thank you for joining us today. Again, everyone, do keep in touch with her. Her LinkedIn's in the chat, and anything you can do to help her would be phenomenal. Rest assured, we would all sleep better knowing that what she's doing has got all your support. Next up, we are going to be talking about more population work and looking at how population health is running on broken memory. And we have a phenomenal interview with, and we're going to be hearing from the founder and CEO from Blockhaven, from our own HITLAB's own Ansley Bowen. Ansley, handing it over to you.
Thank you so much, Stan. And today we have with us Justin Castle, who is the founder and CEO of Blockhaven. Thank you so much for being with us today, Justin. I would love if you could introduce yourself to our audience, and then I know you have a great presentation to share with us as well.
Absolutely. Thanks, Ainsley. Give me a second to share. All right, I think you can see my screen.
Yes, you are all good.
All right, thanks for having me. I appreciate HITLAB for having me do this presentation. Happy to be here. I'm Justin Castle, founder of Blockhaven. At Blockhaven, we're building what we call the Health Intelligence Network. This is a person-anchored foundation for continuous health memory, and the work stems from a pretty simple observation about how health actually unfolds in a person's life, a little bit from my own personal, experience in health as a human being, and then, the rest of us have our own personal stories of how we interact with health. Let me tell you a little bit about how we see this infrastructure and some of the flaws that exist today. So if you think about population health, I like to think it runs on broken memory. So think about the last time you saw a doctor last week. Maybe it's 6 months before that, a year, maybe 5. Between then, there's a lot of sleepless weeks, a lot of stressful projects, the flu you wrote out on the couch. That's where your health's actually happening. And almost none of that really get captured in a meaningful way. Biology, behavior, environment compounds over years, but the systems that we have for population health and healthcare in general really only capture discrete episodes. These could be encounters, claims, snapshots of the overall truth. The memory breaks at every boundary, and you can think about this from payer switches, job changes, clinician handoffs, platform migrations, and every population level calculation built on that foundation inherits this fragmentation. And this isn't because there is just incomplete data. There really was never a continuous base or infrastructures to support this. And this is what explains why care stays reactive, costs stay high, and equity efforts stay misdirected. So starting with the nature of memory itself, we've all been through this. You switch jobs, change insurance, move cities, find a new primary care doc, and somewhere in that transition, the thread of your health history gets lost. The new system starts from zero, not because anyone wants it that way. It's really because the infrastructure to carry a continuous health record forward across institutions just simply doesn't exist yet. A hospitalization ends, a claim is paid, insurance changes, a new specialist is seen, and the record starts over. And for us as individuals, the longitudinal thread is severed. For populations, the effect magnifies. You can think about surveillance, risk stratification, trend analysis. All of this relies on stitching together those broken segments. The aggregates are not partial views of reality. They end up being episodic artifacts rather than continuous lives. And ultimately, the field ends up not working with continuous data. And the continuity was never present because there was no place to actually keep it. And you can think about research following the same pattern. Think about EHRs. Large real-world evidence studies rely heavily on electronic health record data. Investigators extract records, define cohorts, analyze outcomes, and publish conclusions on disease patterns, treatment effectiveness, and population risk. But those records only contain an episodic fragments capturing institution-bound systems. The patient's full continuous trajectory, including care received elsewhere, gradual changes over years, remains really invisible. The research treats these broken pieces as complete evidence. Broken memory doesn't only distort randomly, it actually produces specific failures in 3 places. If you think about these places, care delivery, cost, and equity, each one of these inherits the same broken memory in a different way. So let me take you through one at a time. So for care delivery, you think about this as a series of restarts. And the irony is, care setting is probably the worst place to reconstruct someone's history. You're in a crisis, not feeling well, stressed, trying to remember medication names from 6 months ago. We've all been there. The context that actually matters is the hardest thing to recall when you need it most. So clinicians do their best trying to piece this together to get the full picture of your health, but really hard to see the true patient's real trajectory. And a patient, as an example, with poorly controlled diabetes, they could look very stable in one system compared to months before at another system. The medical non-adherence to their medications they're taking really wasn't ever linked. People miss pieces of the picture. They don't understand the full trajectory. Ultimately, your health is really shaped by years of compounding factors, and this primarily stays invisible. And it's mainly because there's no really infrastructure to support this. Ultimately, coordination collapses into disconnected handoffs, discharge summaries reference only admission at one hand, referrals carry forward whatever history the sending institution is able to document, and preventable escalations follow. Chronic conditions get managed episodically rather than an evolving process. And this really isn't a failure of will, it's a failure of infrastructure. The system was never really given a place to hold a whole person in one place across time. And the same missing memory drives parallel distortions in cost. So when you switch providers, redundant testing, duplicated diagnostics, reactive interventions, ultimately a patient changes payers, the new system without a prior record orders the same imaging again, utilization spikes, emergency visits, preventable hospitalizations. Because early intervention opportunities were lost, this resets. Analytics and AI only amplify that. More sophisticated models running on fragmented inputs produce higher confidence but still distorted outputs, and greater precision on the wrong overall object. And these distortions don't fall evenly. So you think about populations with unstable connections to the healthcare system, those facing frequent job or insurance changes, lower household income, groups subject to systemic barriers, rural or mobile communities. These experience the most frequent resets, and their records are the most fragmented. Public health data therefore underrepresents the true burden of disease. Interventions built on these skewed aggregates target the wrong priorities or miss entire subgroups. And equity metrics look improved on paper because the missing data creates an optimistic bias, while ultimately the lived outcomes lag. When population health resets on broken memory, the populations most affected of fragmentation are rendered least visible, and data-driven equity efforts widen the gap they intend to close. Interoperability standards, data lakes, and advanced analytics sharpen the image of these fragments, but they do not restore the continuity. If broken memory is the root, then the answer should be continuous memory. So I want to show you a little bit about how we're thinking about this at Blockhaven. So think about a tree on rings on a tree. You can read the history in its cross-section. Each ring is a year lived, some thin, some thick, some scarred, and every ring is there. The tree doesn't discard last year's ring when the years form, it accumulates. Your health really works the same way. Your body carries forward every prior state, and most of that thickens the ring isn't a diagnosis or lab. It's a random Tuesday, the week you slept badly, the stressful project, the daily walk. These are the moments that actually shape health, and none of that actually really gets captured or meaningfully understood. The good news, most of the signal captured passively now. Heart rate, sleep, activity, stress, recovery, we all have some sort of device doing that. But there really is nowhere persistent to store this and really understand it in aggregate. Your health, I see it as a living record. Each moment thickens the trajectory. None of that really gets overwritten. That is the metaphor we build against at Blockhaven. What health needs is one continuous thread, a time-consistent understanding of a person's health state across a lifetime. Not really a snapshot or a chart pulled from one system. The whole pattern remains intact, and we call this substrate of Blockhaven health memory. So you think about health memory as a continuous living memory, accumulates across your lifetime. Each signal point thickens the record. None of that gets overwritten. Nothing gets normalized away to fit a schema. Contextual in the center, decisions meet what came before, not just what a single encounter happens to capture or understand, but the full prior state, medications, exposures, patterns, your life context, accessible at the moment that it matters. And ultimately, sovereign, authorship remains with you as a person. The keys to this memory travel with the life. Continuity is not granted by an institution, it is the property of the person's record. Ultimately, this is not really a better EHR. It's a different base unit. You can think about an encounter was a reasonable primitive if you want to think about billing, but it's really insufficient for understanding continuous biology. And sovereignty here is not just rights, it's the architectural reason the network downstream can learn without extracting from people. Because the person holds the keys, learning has to come from the vault instead of pulling data out. This constraint is what makes next come possible. So let me switch slides. So you think about this as the health intelligence network at Blockhaven. We're building towards this ultimate mission. It's a privacy-preserving learning layer built on that continuous thread. 3 scales compound under 1 design constraint. Learning happens without the data ever leaving the person. The training signal is continuous biology captured at the individual layer, not institutional documentation. That distinction is what lets a network built on health memory learn things prior federated health efforts could not reach. At the individual level, a model can actually be trained on a person's life. Most of what gets called personal AI today is really a general model with a chat history glued on. And that is memory, but not true state understanding. A real personal health model needs 3 core things: continuous signal capture passively, on-device inference so that the data stays local, and model artifacts the person owns. That combination is what really makes anomaly detection and true understanding shifts from your baseline possible. And this really is not a population average, but a hyper-personalized approach to your own health. At the clinical level, that same continuous signal gives clinicians context they never really had. Prior medication response, adherence patterns, ambient symptom trends. The big shift is what becomes measurable. Value-based care has really struggled for a decade because clinicians and payers couldn't agree on the signal they both trusted. So contracts ran on readmission counts, ED visit counts, the only proxies that a payer can really observe. On a continuous substrate, both sides could reference the same trajectory. Attribution would become precise, which care setting improved, which outcome traceable across every clinician that touched the patient. Care stops getting measured by what was billed, it starts getting measured by what really works and true outcomes. At the population level, the mechanism becomes possible is federated learning. Instead of pulling data out of institutions into a central data lake, a research question would be sent to participating vaults. Each vault would then run the computation locally on its own data. Only the answers returned, no central repository, no extraction from the person, and no lake of PHI waiting to be breached. We all know how many data breaches are happening recently. And because a consent is bound to the substrate, research consent would not require reconsenting at every new study. The research accelerates, individuals stay sovereign, everybody wins. With this design in place, new capabilities become tractable. You think about rare disease cohorts across geographies, dispersed individuals, post-market surveillance on continuous biological signal instead of voluntary adverse event reports, living guidelines that update as evidence accumulates instead of waiting for the next RCT cycle. None of these really are possible on fragmented data. All of this does become possible on a continuous person-anchored one. And finally, equity. We named this earlier, mobile, low-income, marginalized people, the one whose records reset the most often, whose lives fragment across institutions. These are the populations that we really do need to learn from most for health. They are the populations that are most reliably erased. A continuous person-anchored substrate inverts that. When the record travels with the person, mobility stops erasing them. When the signal is passive, heart rate, sleep, activity, adherence, language, and literacy stop hiding. Evidence assembled on the foundation finally includes the people that are currently left out of the equation. And every person remains present in evidence, including the ones that you cannot see currently. So when I say population health runs a broken memory, this is the answer, not an incrementally better interoperability, a different substrate entirely, and a network of privacy-preserving learning that compounds only when that substrate is sovereign. Population health cannot run reliably on broken memory. True progress in care will require the consideration of delivery costs and equity anchoring to a persistent entity. Recognizing this distortion is really step 1. Replacing this is the work. That's what we're building at Blockhaven. If this resonates, whether you're a health system, a payer, or researcher, really love to chat. My team and I are always looking to continue the conversation. You can email me or reach out at Blockhaven AI. Really appreciate the time and hand it back over to you, Ansley.
Thank you so much, Justin, for coming on our program today, and we look forward to hearing more from you in the future.
Thank you.
All right, and I'll hand it back over to Stan. Thanks, everyone.
Perfect. All right. Ansley, great interview. And everyone look up Blockhaven and do keep in touch with what they're doing. We're talking about some pretty revolutionary technology that's right in the middle of patients and what they're doing and what they need to do. Next up is another person who's going to be at the summit next week. And hopefully you're going to be there to see him. If not, don't forget to sign up today to get your tickets as we are selling out fast. And looking forward to talking to Yusuf. Yusuf from Indigenous. Hi, Yusuf. How are you doing?
Hey, how's it going, Stan?
It's going well, and looking forward to seeing you next week. How are you and where are you?
I'm excited to join you guys. I'm in Washington, D.C., getting ready to head up and join you guys for the week of festivities up there starting Sunday at the baseball game.
That's right. Looking forward to seeing you as well. Tell us a little bit about, let's start with your journey, if you could, a little bit about your background and how you got to Indigenous.
Yeah, no, appreciate it. So yeah, got to Indigenous, former military special forces background. So I've been in healthcare for 30 plus years. Joined the FDA after tours ended due to injuries. Started realizing quickly as I did device and drug approval at the FDA when I joined them, that there was a little bit of skew towards one population in the clinical trial research. And so over the years, as I got more developed within the science, I ended up working for Mount Sinai Medical School, where we were recruiting veterans. Given my background as a veteran, we were losing veteran to suicide, and started to see the trials and tribulation of actually recruiting Black and Brown patients within communities. And so, COVID happened, as everybody could remember. We started to see that play out in the rapid development of vaccines around COVID. And so that problem still existed. And so Indigenous was formed really to address increase in more differentiated data. And then personal story, my twin daughters who were 25 this year were diagnosed with a rare genetic eye disease. So that further amplified the need for us to have more women and ethnic groups within the clinical trial space so that we could drive better drug discovery across the globe.
Incredible. That's an amazing story. And it sounds like a pretty massive blind spot for healthcare and life sciences, not only in terms of, coming up with better treatments for patients, but also even being able to develop some targets for people that are really in need these days all over the world, not just North America and Europe, but all over Asia, Latin America, and Africa. If you could give us a little bit more about the how. I mean, it sounds like you've found an extraordinary blind spot here. Tell us a little bit about how you're building Indigenous as the world's first representative genomic biorepository.
Yeah, no, look, it's been tough challenge as you could imagine. We're no longer after COVID, isolated between North America, Asia, right, and the Caribbeans and South America. So really what we're doing is to look at federated model on how to recruit and aggregate large repository of data set across the globe. So give you guys that's on the call that are familiar with the genomic space, the UK Biobank, right? Massive undertaking, $10 billion plus. Unfortunately, the clinical trial sites that's the underpinning of that led to a 88% European white male repository. We're looking to do the reverse of that, right? Because it's just good science. So Indigenous is looking to build out a repository that is a lot more inclusive of women, more genetic variability that are been studied for decades. That's within the African diaspora, Indian diaspora, South America, Hispanic diaspora. So we're looking to culminate all of that data set on a true platform, which is where we're building with our partnership with Oracle, so that we can have a federated data model that could then sequence this genetic data on site within country, protect that data sovereignty, but able to aggregate that large data set anonymized within a cloud environment so that we could then truly look for novel targets, which are going to be needed if we're truly going to be intentional around in precision medicine. Right now, the data sets is just skewed to one population. So, unfortunately, we won't see a lot of efficacy in treatments that are being developed, especially cell and gene therapy, if we don't have a more differentiated data set. And so that's the core model of what we're building, looking for the alpha genome within communities that have been through austere conditions, which have built a lot of resistance, visibility on certain disease areas that are amplified in certain communities, and then being able to find those novel targets that we can then move forward with more efficacy around some of the cell and gene therapy that are going to be developed in the future.
And I think as we're looking at this as this kind of not just this revolutionary platform, but really the detailed insights that it's going to help patients and researchers build better medicines. Talk a little bit about the patents in medicine, and certainly, biomedical informatics and bioinformatics are really important. They're cornerstones of what's going on for so many ways. What are the patents that you guys have filed for to help protect what you're building here?
Yeah, no, good question. So look, we had to kind of equivalent to a surfer, right? We had to wait for the right wave, and given the new administration, there were a couple of areas though. So as you know, the DEPICT Act was kind of the DEPICT from the FDA was really looking at increasing more genetic ethnic groups within the population into clinical trials, 2 or 3 years ago. What we started to see now is that we really needed to get under the hood and be able to provide that privacy and security that some communities have lost trust within the healthcare system. So, being my healthcare background, I saw what large fintech groups were doing around fintech and blockchain, and we really started seeing the value of adding a blockchain platform and finding a cloud provider that embraced blockchain, not in the way of course, fintech and crypto, but really looking at how we could provide that transparency and the privacy. So blockchain idea really kind of helped us galvanize, and then the Genius Act and a couple of the acts that has been approved here, the Biosecure Act, since we're literally in a genomic race with China and others across the globe doing this genomic sequencing initiative, we decided that we thought it was important to have a platform that will be able to be patent defensible. So yeah, Indigenous is building a blockchain platform with Oracle and Oracle blockchain. We've able to file a patent last November. And we're increasing the patentability around that every day, working with HITLABs, of course, as we flush out the science and validate some of the moats that's around our business model. So currently, we have one patent filed within the blockchain and financializing the genomic data as an asset. And then we'll be adding a few more as we start to build our first trusted research environment, which will be online October 2026, which will then add some additional patentability around using agentic AI tools within our platform so that researchers don't have to pull data out, do their analytics, and then ingest that back into consortium. So we're pulling that end-to-end solution where researchers will be able to do everything that they need to do within our platform.
Yeah, and your platform is really extraordinary, right? You talked about it already, but it's really not just the bioinformatics side and the genetic side. It's really the AI that's really magnifying what you're doing. But what you're doing is revolutionizing how people define an asset class in life sciences. And so, I think people they talk about it all the time, but the actual significance of that is not necessarily hitting everyone in the same way. From you and your background, you talked about it in terms of how it's affecting your children, and obviously you have a deep background in life sciences with all your work in the ecosystem over the last 20 years. What does that mean to you in this new asset class that you're making for not just the discovery of new cures for disease, but also therapeutics for things like like you talked about sickle cell, but other major diseases too, like cancer and diabetes and heart disease?
Yeah, no, look, as I think some of the panelists have mentioned, man, this is a game changer. The environment, AI is moving rapidly to create infrastructure for us to do this, right? Larry Ellison wants to produce medicine within 48 hours, right? Personalized medicine. So all of these things, and then, the rapid development of AI and agentic tools are able for us to really do this. So, yeah, the big component of this is just making sure that that data from an asset class, right? We're looking at how the novel therapeutics have been developed in the previous, historical with pharma. Since I regulated pharma, it's been one-sided, right? The value has never really been distributed to the patients that are driving a lot of these novel discovery. Given a Henrietta Lacks as an example, right? Her cells created $1 trillion industry, but that didn't really trickle back down to the individual patients and the participant. And so that's a major driver for us where individuals that join our platform and contribute to science, one, will have the transparency to see how they're impacting science, but we're also building a mechanism where the individuals on our platform would also receive some of the compensation and benefits from being in those particular clinical trial and driving the asset value as it develops over time. Because as you know, Stan, individuals with comorbid conditions are value add because you'll be able to look at whole genome sequencing data from these individuals. So you'll be able to get a lot of insights and drive a lot of novel targets downstream, which is our goal. But right now we're staying in the data. We're a data play company where we're trying to aggregate more differentiated data that could be also in comparison with what's already out there, which unfortunately is a little skewed towards one population.
That's right. And so, I mean, this is extraordinary. Not only are you creating a new asset class by combining genomics and AI, but now you're also talking about a new way of helping patients become a part of the monetary upside of these new inventions, which is truly revolutionary. Talk a little bit more about privacy as we get into this and as your model expands, which no doubt it will. You're going to see a lot of people want to know what are the data protections, what are the privacy protections for indigenous bio, and talk a little bit about that. What are you guys doing to shore up some of the infrastructure around privacy and safety?
Yeah, no, look, that's what keeps me up at night, right? Being an FDA regulator, so I'm being held at a higher standard, if you want to think about it. So yeah, no, we each country, we're working with each country as we start to build this relationship, right? The U.S. has, HIPAA laws and patient privacy laws that we're adhering to, and will be able to enforce those given our CTO's background in cybersecurity, who previously worked for Johnson and Johnson. And so we're forming out a strong cybersecurity and data governance team. Former FDA colleagues of mine have agreed to join as advisors. And then, again, like I mentioned to you, we went with a particular provider as far as cloud provider because we wanted to see that innovation, right? And so Oracle has if you look up Oracle blockchain, they've really started to put a lot of resource and intentionality around the privacy around data. There's no secret. You heard the last couple of days that the UK biobank was breached. So we're going to be under a lot of scrutiny, but we're building our platform based on some of the failures of others that has gone before us, right? 23andMe and the UK biobank. And so our goal is to make sure that we shore up those areas that, were failures on those parts, but also thinking about the future, right? As we build this platform, we're also thinking about what could come up next downstream, right? So we have quantum, which is another area of interest that is still developing. So we're going to make sure that we're staying current with the times, making sure that we're meeting all the compliance, regulatory, and also international GDPRs. And also different countries have their own regulatory data governance. We're going through that right now with South Africa, and I'm heading to Nigeria on the 12th to talk to their data governance folks as we start to recruit a large repository of African genome in Nigeria.
That's outstanding. No moss growing under your soles. So that's good to see. And of course, between now and then, you'll be in New York City at the HITLAB Summit. Again, thank you, Yusuf, for joining us. For anyone who wants to meet Yusuf in person, please don't forget to sign up for the summit or reach out to him on his LinkedIn at the chat, in the chat here in the chat. Thank you for joining us, Yusuf. Great talking to you.
Appreciate it. Thanks for your time, Dan. It's Stan, and see you in a couple of days.
Looking forward to it.
Right.
And again, if you want to sign up, please do. We're looking forward to seeing you in New York City in the next few days. And then as we dive into the second part of the second hour here, we're now going to jump into a conversation with Bhagya Prasanth. And Bhagya, are you here? Can you hear me?
Yes, Stan, I can hear you loud and clear. Happy
Fantastic. We're going to talk about how we can connect care, and by connecting care, how we can make sure that care is more accessible, more affordable, and a lot better overall. So first of all, if you could just give everyone in the HITLAB community a couple of minutes of your background and what got you to HICS Connect.
Yeah, great question. So my background, I've been in healthcare and building healthcare product close to 20 years now, have been built many products and technology enablement for clinicians to administration, being on the providers and also the payer side of it. To me, what inspired HITLAB Connect was a simple reality, Stan, where healthcare is still fragmented across patients, providers, and the payers. We all know it, and especially most importantly, this community. And we're really kind of looking to solve for that true connectivity, creating that invisible layer that where data and the decisions flow seamlessly. When that happens, then the care becomes more continuous, providers have full context, and payers can proactively manage the outcomes instead of reacting to the cost and the pressures that payers are under these days.
Incredible. And that's a major pressure that they are facing, right? And so
Yeah.
when you look at those pressures and when you look at the issues around coordination, how can digital platforms help support care coordination across patients, providers, and communities to help improve the population health management issues that we're facing today as a society?
Yeah, I mean, excellent question, right? Because to me, the data doesn't coordinate care, but the connected systems can, right? So digital platforms really need to become more of a coordination engines, not just the data systems. Hey, my job is I'm going to move something from point A to point B. So that really means like shared visibility across patients, providers, and payers. So everyone is aligned in close to real time as possible. When you really connect that clinical care with benefits and the community resources, and you move that disconnected touch points to truly a coordinated ecosystem where as a patient myself, that my provider understands where I am and my payer knows what it's going to cost. And I have the right resources to manage my care proactively.
Yeah, I think the proactive component of that is the most important because that always provides the biggest challenge in terms of how to be proactive. But again, that data connectivity is so important in providing the option, the ability to be proactive. And when you look at that, what are some of the biggest challenges that you're seeing in improving the access to care, proactive access especially, and how is your technology helping bridge those gaps?
Yeah, great question. So in my point of view, like access isn't just about availability. Just because I have a program with my payer or just because I have a provider that I can go to, it doesn't mean it's access, right? So availability doesn't mean access. It's about the navigation and the timing, right? So am I able to get to what I need to get to at the right time? So to me, the biggest challenges are fragmentation, inequity, and late engagement. So patient struggles to navigate. Candidly, I've been in healthcare for 20 years. Even today, I don't know why my pharmacy doesn't understand the prescription my provider is prescribing. And pharmacy is getting a denial from a payer. And then now pharmacy is going and coming back to me and saying, hey, this is declined. Go talk to your doctor what he prescribed because it isn't covered. So that's a very personal experience for me in terms of being able to navigate when you need it the most, right? So technology can shift this by simplifying access, in my view, enabling earlier interventions that goes back to the proactive aspects, And then how do you actually proactively identify at-risk population, moving us from that reactive care to more proactive, preventive, cost-effective care in general?
Yeah, and that's exactly where we've got to take this, because cost effectiveness and efficiency, when it comes to cost, affordability is what drives a lot of the accessibility for so many people. What are some of the solutions that need to be built in terms of both scalability as well as user friendliness for populations in need? And how do we build those?
Yeah, no, excellent question, because we don't have shortage of many digital platforms, Stan, in the group here. I think we all know that. The reality is if people don't use it, then there is no scale. So from that perspective, what we are focusing on, how do we think about like a real world use, not ideal conditions, right? So what that means is we're thinking about a caregiver, a patient themselves, or like a payer that has their own constraints in general, or a provider for that matter, in really understanding what are those realistic situations that this ecosystem of stakeholders and the individuals really are involved with, to really build like, it's intuitive for patients and it makes sense for providers and transparent for the payers at the same time. And we are focusing on that simplicity and the interoperability together to truly make it more adaptive and usable in the long run.
Incredible. I love it. And I think when we're looking at the usability and we're looking at scalability, they're so tied together. And as you're looking at how this is coming together, what's most exciting for you, and what are you most excited to share and to do at the summit next week, since we're going to be hosting you as well?
Yes, yes. So great. Yeah, I'm just looking forward to personally, I'm so looking forward to get to connect with this ecosystem and what you have created here, Stan and team. And also, when we think about solving the healthcare problems, connectivity is really becoming healthcare's biggest multiplier, right? So I'm excited to share how connectivity is becoming a shared value driver for many stakeholders. So when you have patients, providers, and the payers are aligned, you just don't improve experience. You're absolutely improving the outcomes and reducing the cost for everybody. Because the reality is, when we all know the waste, the administrative burden within the healthcare ecosystem, it directly hits all our pockets. It's not it's personal. So it's personal for me. So I'm really kind of focused and dedicated to see there got to be a way to solve for this when you truly enable that interconnectivity. Yes, it's extremely difficult. I'm probably not the first one that has taken on this journey to solve. This entire ecosystems are trying to build and solve for those different pieces and aspects of it. To me, again, that's where I'm excited about, like, how do we have that connected ecosystem where, as a patient, as a provider, as a payer, because those are the three entities where we are not playing the phone tag, right, all day long. So healthcare transformation, to me, it isn't about adding more technology. It's about really connecting what already exists, and many brilliant minds are built and enabled. So at HIX Connect, we are making that connection work for patients, providers, and the payers at scale.
Yeah, and that's so critical to get this connection going and to scale those connections. And like you mentioned, there's so many people out there trying to do this. Talk a little bit about how HIX Connect is different from the different types of connectivity platforms that you see out in the ecosystem today.
Yeah, no, that's a great question. So to me, it's different in a couple different ways. I'll just state like at least three things, Stan. Number one, we know technology can solve for any problem. At HIX Connect, how do we make that easy button for organizations that want to enable that interoperability capability? Number two is, I don't know how many can confidently say, I absolutely have a longitudinal view into what's happening for a patient between your medical aspects of it, our mental health aspect of it, our behavioral health aspect of it, where HIX Connect is being really be thoughtful about, it's not just about interoperability, like how do you provide the right signals at the right time? That's the other key aspects, that we are connecting the ecosystem, but at the same time also providing the right signals at the right time. And the third is absolutely about, many of us are adapting AI, but HIX Connect is intentionally, our goal is to truly become that foundation that AI can be successful on, right? So to me, those are the key aspects and the lens that we are taking to how do you make it an easy button? How do you provide the right signals at the right time? How do you make many, many AI capabilities and the enablement successful?
That's fantastic. And obviously, we've used the word AI, the term AI, a lot over the last 15 minutes or so. Talk about how you see the future of AI coming together with connectivity and data connectivity in healthcare.
Yeah, to me, the AI can be a differentiator and the game changer, provided it's used for the right purpose, right? Especially in healthcare, that's such a critical thing, because getting it wrong is not an option, right? So because it can, cost somebody a life in making wrong decisions at the time. So to me, AI can be a game changer for automating many, many administrative things that the provider needs to do, or like the payer side of the things happening. So when you have the right data, the right foundation, right signals, I'll say, not even data, because data doesn't tell the story. You have the signals and the insights. To me, that's where your AI can be that amplifier to take your outcomes to the next level.
And that's just exactly what we need to see, and what we're hoping it can do
Yeah.
to help improve everything that we just talked about in terms of population health and everything else going on.
Yeah.
And so when you're thinking about AI and you're thinking about the future of data connectivity, how much do you think about avatars and robots? How much will the connectivity spread and dial up into a lot of the wearables that people are wearing today? Is that the kind of thing that we can expect with the kind of platform that you have?
Absolutely. That is something we have thought about, because when you think about the connectivity, our human lives are evolving in general, Stan, right? Because many people don't rely on your traditional modalities to get to the health insights you're looking at. So wearables and being able to connect that, whether that's wearables or like you're getting a care at an in-person care setting, or like you're getting the virtual care. So we are looking at across those modalities of how individuals are engaged when it comes to their health and the health aspects. We're absolutely thinking about how do you build that connectivity across that ecosystem, again, between patients, providers, and payers, but most importantly, from a patient's perspective, how do you connect that to the providers that are caring for that individual?
That's fantastic. Well, again, Bhagya, thank you so much for your time today, and just amazing work that you're doing with HIX Connect to get our data connected between all the different healthcare providers we have, and obviously all the wearable data we have, whether it's the Oura Ring or the Apple Watch. We all need to have that data connected better every day. Thank you, Bhagya, for joining us today.
And thank you for the opportunity.
And again, for those of you who want to meet Bhagya in person and hear more about HIX Connect and everything they're doing to connect up everybody, please join us next week at HITLAB Summit and at the Microsoft Tech Center as a part of the New York City Health Innovation Week, NICHI, May 5, 6, and 7. And another person who will be joining us for the New York City Health Innovation Week and is one of the major players in the ecosystem, particularly in this time and day, is Jim Fisher, who's a partner at DLA Piper, one of the major groups that helps put together people. Jim, how are you doing?
Well, how are you?
Good, good, good. Thank you. So really, again, DLA Piper, Jim, is such a massive player when it comes to transactions in the healthcare ecosystem when we're talking about bringing two companies together, two assets together. Maybe if you could give our audience a little bit more of an idea of what you do and what DLA Piper does.
Happy to. Good afternoon to all of you, and thanks for the opportunity. So DLA Piper is a global law firm. We have offices in 90 countries around the world. And, we have a huge focus on life sciences in terms of both providing legal advice, obviously, and also just trying to be a good steward of the community. So all of our various offices around the world have a keen focus on not only the local issues, but the global issues. And we're fortunate to have two global co-chairs that coordinate us around the world in the many jurisdictions. Most of our clients these days are thinking globally. Very few of them are thinking just kind of in a local sort of atmosphere. So we really do think that our platform and our experience and our dedication to the space helps us stand out.
Yeah, and the HITLAB community certainly is familiar with one of your bigger clients. I don't know if you could say your favorite client, but certainly the Merck Global Fund and the Global Health Innovation Fund from Merck and Bill Toronto, who chairs the Breakthrough Alliance here in North America and is on the Breakthrough Europe and Breakthrough Asia boards as well. But tell the community a little bit more about what you guys do, because law firms, when you say law firm, that can be ambiguous sometimes. And in healthcare and life sciences, it means so many things because there's so many areas where healthcare and life science startups or even A and B round companies need your support. And I know Bill and his team at the Merck Fund have been relying on you for almost a decade or more now. Tell the community what that entails, because you guys do a lot of different things.
Yeah, happy to. So I think that the big misconception, I think, of law firms is that we just are there to paper certain types of transactions. And yes, of course, we do that, and we're very active and enjoy sort of the venture side of our practice, which is the formation, the representing of investors or companies and their fundraising processes, whether that's a small Series C round or a safe round or convertible note round on through public offerings. And that's kind of what people, I think about for the most part when they hear Jim's a corporate lawyer at DLA Piper, and that's sort of what he does. But the truth of the matter is it's much more than that, and sort of the platform that DLA offers is quite unique in that we focus on all stages of sort of a life sciences company in terms of how it grows. So we have a massive regulatory practice, and what does that mean, right? That means FDA support, that means technical support, IP support, cyber support. It means AI support, and not just from the standpoint of counseling people on what AI means, but also using it. We have a very large sort of protocol in place here, and we have for several years now, where we actually employ and deploy AI in both a proprietary way and through shared tools to sort of help our clients become as efficient as they can be, and also for us to be as efficient as we can be. And then you carry that through all the way through sort of the global kind of atmosphere that we're involved in, right? And so those aspects of what we do carry through all of the jurisdictions in which we work in. And one of the key things for us is that sort of cross-border understanding, frankly, on the regulatory side more than anything else, of how our governing bodies, how's the FDA speaking with its counterparts in various parts of the world about various issues. So we have not only that legal side, but we also then have a consulting side, which helps us enormously. How do we navigate through various different sort of political circumstances or means? And obviously our principal role is always going to be lawyers. That's what we are. We try to offer, and I think do a very good job at offering, other aspects of counseling and service where we can through our other sort of affiliates and product offerings to sort of create a holistic approach to both a startup and really sort of, as we view it, is if we help you form, we want to be with you until either your exit or your public offering or your sort of next stage in life. And we're I think uniquely positioned to be able to do that through your various stages of growth.
Yeah, there's no doubt. I mean, no doubt about it all. We've seen what you've done with the Merck Fund and helping their portfolio companies along the way. And tell us a little bit more about how you would recommend founders think about their legal strategy when it comes to balancing what they're doing relative to the speed of innovation and AI today, as and then the regulatory and compliance requirements that they face in the U.S. healthcare system.
I'd start by saying take a step back, right? And there's always sort of a keen sense and urgency to get started, and we certainly respect that, and we know that all people need to sort of move fast, but you need to move fast in an efficient way and in a way that lays the groundwork, right? A solid foundation for what you're going to be doing going forward. So a lot of times when we come in, if we're fortunate enough to come at the ground stage, we're going to be asking questions not about tomorrow, but about 3 or 4 years down the road, right? Where do we see you going? Where do you want to be going? what have we seen with people in your space that we can kind of bring to the fore to suggest maybe alternative paths or structures? The idea of getting it right in the beginning is obviously what everybody wants to do, but sometimes that speed causes people to make subtle little, sort of decisions that ultimately either have to be unwound or changed or explained down the road. So our key kind of focus with early stage life sciences companies is getting sort of that foundation correct, so that when they go raise money or when they're going to speak to a regulator, to the extent that they've made decisions, we know why we made the decision. We can explain the decision. If there's, perhaps a more risky decision versus a more conservative decision, we can explain why we made that decision and why it was supported by sort of the ideas behind the platform and what have you. So for us, foundation is first. Structuring is keenly important, and trying to think as far in advance as we can so that we can plan as much flexibility into a structure as possible. Obviously, that can change over time, and we want to frankly be thinking about that too. If there's going to be a pivot, how are we pivoting? Why are we pivoting? And is your legal structure created in a way that allows as much flexibility as possible within the current sort of regulatory regime we find ourselves in?
That's fantastic. And I think that really does hit upon a major trend that HITLAB sees. And HITLAB, again, we're more of a testing laboratory, but we do see a lot of technology companies now growing and scaling and getting ready for more investment or getting ready for some sort of exit. And so really what you're talking about, Jim, is legal infrastructure. And maybe let's double click on that, because how does that legal infrastructure play a role in helping these startups and these founders scale effectively, but also get ready for being able to attract investment or a buyer?
I think that the most important thing as you think about an early stage company preparing for its life cycle is, how am I going to present to the people that I'm trying to raise money from? And what I mean by that is, the more prepared you are, not only on the technical side, which of course, we trust and have enormous faith in our clients that they're doing, and that's their expertise, but how are they structured in a way so that the financial side of sort of their house is well heeled and prepared. And so there's a couple of really basic things that you want to be thinking about, right? You want to have sort of as simple of a structure as you could possibly have that has the most flexibility as possible, without creating sort of a scenario where people will come in and look at it and say, this structure isn't, for example, ready for global expansion because of the type of entity you selected, something tax driven, so to speak. Or you've set up an entity that creates sort of a problem from a regulatory perspective, because those types of entities aren't necessarily recognized in various parts of the world in terms of various different treaties and things along those lines. So what we're trying to figure out is, where do you want to be? Where do you want to go? How do we create a structure so that when you go in front of either private equity firms or CVCs like Merck, a wonderful company around the world, right? How are they going to react to the structure? Are they going to look at it and say, okay, we've seen that before, we understand that, we can explain it? How do you make it as simple as possible? And how do you move the conversation away, frankly, from legal and structuring to what you guys really want to talk about, which is your product offerings and your research and sort of your techniques going forward? And our goal is to focus that, to allow you to focus on that and to have as little, kind of conversation around legal topics as possible.
Okay, that makes a ton of sense. And you talked about how DLA Piper's in 90 countries around the world, which is stunning. And certainly the lab having now a benchmark of about 300 studies a year, we're looking at these technologies every day. And a big part of where they're getting value and they're getting investment is through their intellectual property. And so you guys do a lot of work in that area. And there's a lot of misconceptions about this. Can you identify for the audience a few of the biggest misconceptions that entrepreneurs have when it comes to protecting their IP and managing that risk?
Yeah, happy to. I should make sure I'm clear. It's 90 offices in 40 countries, so it's a lot of countries and a lot of offices. But on the IP side, I think there's a couple things I think that are most important. One, there's this sort of feeling, right, that okay, I've filed something and therefore it's good, and I have either a trademark or a patent application or something along those lines, and it gives people a nice feeling, and it should, right? It's value, it's creation, but was it prepared in a way that you can expand with it? Was it prepared in a way that you can take it global if you need to? Was it vetted in a way that you can have you can do as much as you can to avoid having to either redesign or spend a heck of a lot more money, frankly, down the road to either search or correct or what have you, either in the patent space or the trademark space. The other thing I think people make a just sort of an assumption on is that, well, for example, the US and Europe have very similar kind of structures. Well, yes and no, right? That's not always going to be the case. And so having to think about where you want to be in a meaningful way, obviously within, budget constraints and things along those lines. And again, creating that flexibility is key. And what our sort of intellectual property team and our transactions teams really focus on is sort of that flexibility is, okay, have we searched enough? Have we identified enough? Have we created enough flexibility in what you're trying to do? If we're going to pivot, do we know how we're going to be able to pivot within the confines of our intellectual property? And then the policing of the intellectual property becomes very important. A lot of people will, again, kind of focus on, okay, I have it. Okay, well, if people are infringing upon it and you're just sort of letting that happen, that's a problem. And, we often will come into situations where, people are aware of something minor happening and then all of a sudden it becomes a bigger issue and now you're in a fight with somebody. So policing your intellectual property and protecting your intellectual property becomes keenly important. Look, the use of open source is always, a question mark. And people, I think, unfortunately fall into traps sometimes where they'll say, well, it's just a small component. Well, it may be, but you don't kind of have where that's going to expand and you don't kind of have a sense as to what others might be thinking or utilizing in terms of that open source. And so I would be very cautious. Obviously, it's a great tool, and it's not to suggest that people shouldn't use it, but I think you have to be careful about how you use it. And I think you have to fully understand how you're using it so that you can explain to either fundraisers or your current sort of investors or to researchers or what have you, how and why you're using it, and be prepared to sort of address those points and not be reactive to the situation.
Yeah, I think, and that kind of situation is also kind of the last question here from my standpoint. I know you've got to run in a couple of minutes, but what are some key pieces of advice that you give to founders who are building really, really innovative companies, but are in highly regulated spaces like healthcare delivery and life sciences?
Yeah. So the first is your team, right? Making sure you have, obviously, we're not here to opine upon somebody's quality, but making sure that the legal documents are right, right? We want to make sure there's NDAs in place. We want to make sure there's assignment of invention clauses in place. We want to make sure that the team understands kind of what it is doing as a team and sort of operating in a way that, again, down the road, when someone comes to ask, hey, how is that intellectual property developed, for example, you can show, yes, the company fully owns it. So one of our big areas of focus for life sciences is making sure that there's a very sort of rigorous approach to the creation of intellectual property and the protection of that intellectual property. The second is just, sort of understanding, again, if you've got people in different parts of the world, frankly, laws are very different in different parts of the world. And in some cases, even, neighbors can have very different laws within Europe, within Southeast Asia, et cetera. So making sure you're aware of kind of the idea of having the benefit of being in certain jurisdictions is excellent, fantastic, and we welcome that. But making sure there's not an assumption that just because we're there means we can kind of act the same way, or that laws protects our property the same way, which is not always the case. So we try to focus on the pitfalls without being negative. We're not here to try to be negative, but also trying to identify where is it that you really do need to focus to make sure that, again, those questions down the road can be answered quickly, meaningfully, and move on to the important thing, which is the research and the product delivery.
Jim, as always, every time I talk to you, I learn 3 or 4 new things, and today definitely met that mark. Really appreciate your time for joining us and enriching our community with more knowledge than they probably expected. And again, looking forward to seeing you next week.
Likewise. Good afternoon, everybody.
Take care. Again, Jim Fisher, everybody from DLA Piper, one of the leading, if not the leading, law firm in the world of healthcare and life sciences, and has worked with many, if not most, of the portfolio companies from the Merck Global Fund, as well as many other of the top companies in healthcare and life sciences and digital health. So do look him up, click on him, and link in with him. His LinkedIn is in the chat box. In the meantime, the HITLAB team has put together an extraordinarily important question for you all to answer. We'd like to know about your overall opinion on digital health investment focus. Again, HITLAB is an evidence-based lab, but some of the evidence that we gather is evidence in terms of evidence of opinions and perceptions. And we'd love to know where you believe that most funding in digital health should be directed over the next 2 to 3 years, whether it's in AI diagnostics, remote patient monitoring, digital therapeutics, health operations and workflow automations. We're seeing a lot of innovation there. And then, of course, data infrastructure and interoperability, which you've already heard a lot about from both Blockhaven and HIX Connect. So if you could fill this out, we're going to wind it up in a few minutes here and then write up an article and a paper on it to let the world know what the HITLAB community is postulating, thinking, and philosophizing about. So we'd love to get your feedback on this. If you can take a minute and just click on what you think is the most important area for healthcare to be funding digital projects, particularly in AI, et cetera, over the next 2 to 3 years. And remember, we'll be talking about this next week at the HITLAB Summit as well. So it'll be good to hear your ideas and your thoughts around this. If you have a chance, it would be great if you could talk to a HITLAB staffer and give us a deeper version of your opinion so we can have bigger and better conversations about this, since obviously digital health investments are driving the future of healthcare. What we invest in today is what we'll be using tomorrow, and we're seeing a lot of folks really dive in there. All right, so it looks like we're good to go on the first poll of the day. We'll be doing a few of these over the next 90 minutes as well, so stay tuned on that. In the meantime, we're going to continue onwards to our next speaker and our next topic, which is really going to be focused on how the healthcare system is focused on AI and what the healthcare system is doing with AI. We are in a situation today in the ecosystem where we're seeing a lot of AI out there, and we're seeing a ton of AI driving excitement. However, we are also in a situation where some AI is being deployed and it's not working the way it was advertised. And so those are the manifestations of a lot of pain and suffering for patients that could have gotten better technologies but ended up getting the wrong technology, as well as the staff that are in the hospital or that are in the health plan or in the life science company or in the employer. So now they're using a technology that's really not working, and that's never good. That always provides issues and creates problems for the patient population and everyone else in between. And so that is something where we're always looking for better options and better opportunities in what we're doing. And so that's a big part of the equation. And right now we are really trying to dive into that. And again, if you have any questions about any of the speakers or any of the work that we're doing, do let me know, and would love to get your questions and hear more about what your thoughts are there. In the meantime, we are going to go straight to Accucardia, and we're going to hear now from Moin Husani and hear more about what Accucardia is doing. Oh, I'm sorry. Never mind. The team is now telling me we're going straight to Marianne Rizk, who's just running a little bit behind in doing a deployment for digital technologies and healthcare. And so really happy to have Marianne on the program. I think she's having some technical issues, so she'll be on momentarily, and we'll be getting to that in a minute. And in the meantime, if you do have any questions, feel free to pop them into the chat, and happy to answer any questions that you all have. Hey, Marianne, can you hear me?
Yes, I can.
Outstanding. And do we have video? Hey, we have video.
There we go.
Good to see you. How are you and where are you?
We are back in New York City. Yes, home office. Yeah.
Fantastic. All right. If you could, again, this is Dr. Marianne Rizk from Scale AI. Marianne, if you could tell everybody about your background and a little bit about Scale to start us off.
Yeah, thank you so much. Pleasure to be here. So, Marianne Rizk, I'm our GM of our life science business practice. Really pleased to have been appointed and now running our go-to-market efforts at Scale. Scale is an organization with experience of over 10 years of powering AI breakthroughs. Really started from autonomous vehicles and training that data to being the leader in supporting reliable AI for frontier labs and now building enterprise AI business applications. And so, really exciting time recognizing that we are moving from not just deploying AI for pilots about what the art of the possible is, but now into production. So where that reliability is ever so significant, whether we're deploying at major hospital systems for clinical decision support, that increases time between doctor and patients, saving clinicians some of the administrative burdens, but also focusing back on the patient, whether it's in the fintech area, focus on efficiencies, and then also from a regulatory compliance across government standards and ensuring reliability and safety. And so really, it's all about the trust with clinicians, trust and reliability at healthcare, and then commitment back to patients. And it's such a pleasure and honor to be providing that impact for the organization and the industry.
That's impressive. And again, you're a veteran of healthcare, a veteran of life sciences. You have been with all the major sectors, payer, provider, pharma. You've been with big tech. So you understand what it takes to actually implement AI, to actually implement technology transformation in organizations. Talk to us about what you're seeing as some of the biggest barriers to scaling AI solutions in healthcare and life sciences, and particularly when it comes around to like data quality and interoperability and overall trust. Talk about more about that.
Yeah, thank you. Thank you. I think really this conversation shift is really that trust deficit. I just got off the back of a meeting presenting at Davos Health. We were talking about that, where healthcare is in this reliability gap where it's most visceral and most consequential to make sure that the stakes are really high. We can't necessarily have a model that performs even 90% accurate, right? The benchmark of ensuring that reliability, whether it's on specific oncology workflow, is ever so important. We're now focusing on ensuring focus in whether we're addressing patient population or a clinical context. And the trust gap is where we are not just looking at a KPI, we're looking at human impact, right? And so this particularly is acute right now in healthcare, where we're seeing that the industry is in an inflection point. Speaking to organizations like Mayo Clinic, MD Anderson, Cleveland Clinic, even pharma companies, Novartis, Sanofi, AZ, all of us are looking at how we're driving the impact and ensuring the adoption of reliable AI. And if you think about it, what we're looking to do is, as an industry, is creating solid capability of what the proof, not the promises are. And so, here at Scale, we've actually built clinical and patient-facing agents driving some of that impact. And we've got some proof points. I'm very pleased that I'll be at the HITLAB next week, where we're hosting a reliable AI masterclass, as well as a panel session to really reinforce how we've done that. And so you mentioned the interoperability. I think that's an excellent movement, whether it's the TEFCA movement or the information blocking, really creating opportunities for us to establish the insights needed to create either clinical decision-making or operational decision-making. We at Scale are focusing on a few specific core aspects. So our domain is building evaluations we started our business doing data labeling, right? Being able to validate models and having human experts create feedback and forward deployed engineers. So there's a credible way of verifying that data that's auditable ready, that a chief medical officer or even a compliance officer would seek to sign off. And moreover, you didn't mention this necessarily, Stan, but let's not forget the ever-evolving FDA frameworks for AI and the recent real-time clinical trials, right? And so thinking about some of the transparency needed, thinking about some of the proven insights for real-time decision-making to make smarter go, no-go decisions. What is it going to require? It's going to require trust. It's going to require visibility and reliability and explainability on that infrastructure so that one of the things I've been talking about is how are we scaling care reliably? How are we ensuring that there's no downside and failure? Because in healthcare, we want to reinforce the significant of that evidence, significant of making sure we're creating a level of shared visibility. And a lot of that is around, we've talked about human on the loop. It's not just human on the look, but human on the hook. Where are we driving that validation so cross-functional teams can come together and really think about improving the point of care and making those decisions with clarity and making sure that's continuous review. And I think what's really interesting too, Stan, and just to kind of open it up for more discussion, is that this is where leaders in the industry have a chance where their fingerprints on the blueprint of making the change. This is not an engineering problem. It really is driving the deployment of how AI is being leveraged and utilized, whether it's to create better clinical decisions, operational decisions, and then start to as an organization incrementally determine what gets automated and where you need teams to make key decisions for their business. So
That's
it's
exactly
exciting
right.
time, Stan. Yeah, for sure.
Yeah, it's a very exciting time, and I think a big part of what you said was it's got to be done in a way that is built around trust, and that's a big part of what life science organizations are leaning on right now because they have so much at stake when it comes to regulatory processes, when it comes to patient trust and patient privacy. And so, how can life science organizations ensure that AI-driven tools are being implemented in a way that is safe, that is equitable, and that is clinically meaningful and trustworthy?
Yeah. I think there's three areas in terms of how I would answer that. So, number one, the trust with, let's say, the clinicians, because we're not just building agents that captures a body of work. We're using the domain expertise of MDs and PhDs, using our scale human in the loop engine by embedding the medical context into every model. We're ensuring every output is grounded in clinical truth, reducing errors, enhancing patient safety. I'll give you an example. Within Scale, we've been able to deploy an agent called Patient Record Agent. And what we did is we recognized that physicians were spending more than 30 minutes before meeting with the patient. And so we wanted to reduce some of that administrative burden, reduce that pajama time. And so what we've done is we've deployed our patient review Gen AI solution that was able to summarize and extract all that unstructured data, create some critical prompts and decisions about that care pathway for that new patient, reducing that patient's ability to repeat unnecessary duplication of content, really earning the trust with the patient. You'll be surprised what we've looked at some statistics that the patient's trust with the providers really increases by the number of wait times. So just recognizing some of the human aspects of feeling comfortable, right? Driving that, the surfacing some of that historic data to also prompt the patient to ensure their safety and trust is earned right before even that appointment scheduled. And so from a stats perspective, the trust we built with clinicians is making sure we were very comprehensive of looking at that historic data, which gave 30% time back to that physician, reducing the pajama time for note taking after. We've increased 90% accuracy and increasing on that first instance. The second is a reliability with healthcare. So we're looking at AI native data layer, just to speed up modern medicine, whether we're transforming months of analysis into minutes, and then making sure we've improved the throughput. And of course, the commitment back to the patient, right? Every technological advancement has to translate into a tangible win for the ever so important. These are the hard problems we're trying to face, Stan, right? And so what's exciting too is the way Scale is working is we build a trust layer on top of the existing infrastructure of our customers. We are data agnostic, model agnostic, cloud agnostic. So our customers own the IP. We ensure HIPAA compliance and organizations that can own their own intelligence because a lot of these decisions are being made to treat a patient. along their journey, and then ensuring that we're doing so not only effectively and efficiently, but most importantly, using compassionate use of that data. So I'm really excited, Stan. I feel like this is a phenomenal time to be in this space between the technological advancements, a lot of the policies and changes. From an investor's perspective, we see an increase of these types of modernization being required, right? And so we're so happy to be moving at the speed of our customers. And as many of us know, trust is earned at the speed of trust. And so we're really delighted that we can do this with our customers.
Yeah, I think everyone is. And I think the fact that you're born out of Silicon Valley, really the heart of AI, and the fact that you are now helping bring those best practices to people all over healthcare and life sciences is just a tremendous asset for the industry. And we also have a Scale AI workshop coming up at the summit in about 3 or 4 days now, scheduled for May 5th, which again, for folks that want to attend, please do sign up on the hitlab.org website. You'll find it there. But is there anything we've got about a minute or so left. Is there anything you'd like to quickly tell people about that you're excited about relative to the Scale AI workshop and what they can do to prepare for it?
Yeah, well, we would like to welcome this for any executive, business leader, or technical leader looking to understand how to scale care reliably. You're looking to determine how do you improve clinical precision. You're looking to improve accuracy. You're looking to repeat and create that reliability that gives you the ROI. And you're looking to ensure you've got quality of evaluations and the evidence. That's spelling the care principle that we have. And so come learn about it. We'll love to have you share with you principles of what we've done in practice from private to public sector across industries, but very specifically for healthcare. And so we're delighted to share our insights, and we welcome the organization to learn with us.
It's fantastic. Well, once again, let's give Dr. Risk a loud round of virtual applause from the HITLAB community. And looking forward to seeing you next week. Marianne, thanks for joining us again.
My honor. Thank you so much, Stan. Pleasure's mine.
Just incredible what Scale AI is doing in healthcare and life sciences. And next, we go from AI in terms of organizational transformation to AI around cardiovascular transformation. We have the Chief Product Officer here with us from AcuCardia, Moin Hassani. Moin, how are you?
Doing well. Thank you for having me on, Stan. Always enjoy engaging with the team.
Now, enjoy having you here. If you could give everyone a thumbnail background of your experience and your history.
Sure. Yeah. So AcuCardia is a ECG-led diagnostics company. We have an FDA-cleared platform for automated ECG interpretation to streamline ambulatory cardiac monitoring. And we have a mission to expand ECG as a broad biomarker beyond arrhythmias and even cardiology. And so that's what AcuCardia does. I've worked my entire career in med device, mostly in large med tech companies like Edwards Life Sciences, GE, Canon, et cetera. And I bring that expertise to our applications, AI ECG applications at AcuCardia.
And what inspired the development of AcuCardia? It's such a great product, and again, HITLAB verified. What kind of gap in cardiovascular care are you addressing in the development of this new platform?
Yeah, absolutely. So over the last 2 decades, cardiac monitoring had grown dramatically as a useful tool for diagnosing cardiac arrhythmias, but the system had become strained by the volume and the duration of these files. The process for interpreting and generating reports to the referring physicians was entirely manual. And so it was ripe for automation. We had expertise in ECG and AI to automate the interpretation of those ambulatory recordings and streamline that process to meet the demand where it's at, and to extend the reach of cardiac monitoring into underserved areas and other areas where to other patients that were unable to get access. Beyond that, we saw the opportunity with some publications around the number of conditions that could be potentially diagnosed, the conditions that have a physiological manifestation in the ECG beyond arrhythmia and cardiology, and we started to develop applications there that ended up working. And so we have two beachhead applications, one in structural heart for the detection of aortic stenosis using ECG, and another for monitoring in adverse events like hyperkalemia, which is an electrolyte dysfunction that affects heart failure and kidney disease patients who take cardiorenal protective medications. We can monitor for that condition using ECG, whereas before it could only be captured using a sporadic lab. So we saw that opportunity and we thought, let's build out a portfolio of these algorithms to address and leverage ECG as a ubiquitous, low-cost biomarker and expand its utility beyond cardiology and arrhythmias alone.
Yeah, I think that's such a big part of the healthcare system today, is that ability to not just find it, but also monitor it and manage it better. So tell us a little bit more about the technology itself. How is digital diagnostics changing the way clinicians can identify, monitor, and manage disease earlier and more effectively?
Yeah, so digital diagnostics broadly have, in my mind, four key ways of impacting the way clinicians currently detect and monitor conditions. First, they're enabling detection upstream of symptoms, so screening. So I'll give you an example. We recently published a paper in European Heart Journal on our aortic stenosis algorithm, where we looked at false positives in the algorithm, and we found that the false positives weren't really false positives. Those patients were actually more likely, 4.5 times more likely over the next few years to subsequently develop aortic stenosis. So these were actually pre-positives in a sense. And so what we were able to show was that the ECG was picking up subtle electrical remodeling in the heart that preceded visual hemodynamic changes that would appear in an echocardiogram. And so that's an example of detecting symptoms upstream of the current paradigm. The second is enabling a continuous signal. ECGs can be acquired via wearables or by, like a Holter monitor or a mobile cardiac telemetry device, which is our core business, core market. But also another example of that would be continuous glucose monitoring, which shifts diabetes care from, periodic A1Cs and periodic glucose measurements to real-time continuous recording. So that allows for faster, more tight control of glucose, for instance, in that case. Or in the case of mobile cardiac telemetry, real-time response to concerning arrhythmias that are life-threatening. The third way I would say is individualized risk. So creating digital diagnostics can, create an individualized profile for the risk of a disease. So, is a patient at higher risk? So there might be a broad test for determining whether a patient has coronary disease, like a CT calcium score. But then there are new AI algorithms, digital technologies that are layered on top of CT that enable you to characterize the type of lesions a patient might have. So this would be like CT-derived fractional flow reserved and AI plaque characterization. So that's a way to determine not only does the patient have specific coronary disease, but digital technologies, and AI enabling specific patient risk. And we aim to do that with our ECG-based technologies as well, looking at which patients have higher and lower risk, for example, aortic stenosis. In our same European Heart Journal study, we were able to determine patients that, TAVR patients, prior to getting TAVR, which ones were going to have higher one-year mortality and which patients would deserve or may require a bit more surveillance. Which patients had longer length of stay post-TAVR, which patients have higher pacemaker rate. We could flag those patients ahead of their intervention and determine a personalized risk score for that patient. And then the fourth and final way that I see digital diagnostics really changing the way clinicians work is decentralized diagnosis. So taking all the wearables that are proliferating in the market, like the Apple Watch, the Samsung Galaxy Watch, Fitbit, Whoop, and others, we can gather wearable data, ECG data, and detect conditions outside of the clinical setting and monitor those conditions as well. So for instance, for our hyperkalemia application, we're proposing to use consumer wearables or other clinical grade wearables that have lead 1 ECG built into them to monitor for adverse events like hyperkalemia. And hyperkalemia is one of the leading causes for why patients go off of guideline-directed medical therapy for heart failure and or chronic kidney disease. So if you're able to catch the hyperkalemia and treat the hyperkalemia, treat the potassium, rather than take them off of their cardiorenal protective medication, you can lower all-cause mortality in that population. So decentralized diagnosis and monitoring would be another key way. So those are, in my mind, the key ways in which digital technologies show the vision for the future.
Yeah, this is quite a vision as well. When we start looking through everything that you just mentioned, I mean, you've got to be talking about a calculus of millions of lives being saved every year globally. So now the question becomes, all right, why isn't this done already? And obviously, we study this all the time at the lab. There's a lot of barriers to these sorts of digital diagnostics being implemented. What are some of the top 2 or 3 that you're seeing every day and what you're doing?
Yeah, so machine learning has kind of turned the tables on the technology development process. So in the past, it would take years of R&D time to develop a new technology, core research, and it was years before you could even get to the point of getting through the FDA process and getting to commercialization. Now you can train a model in a matter of a few weeks and have incredible promise of some useful diagnostic or therapeutic advantage from the technology. But the other part of the process of getting the technology to market has stayed the same. So you still have the same barriers to entry or hurdles to cross, like regulatory, like getting a reimbursement, integration into the clinical workflow, the change management of the healthcare community. All of that are still the same. And so I think it's just going to take time to get these new technologies to market. I would say the first barrier that we're seeing right now is reimbursement. On the AI ECG side, for instance, there are new CPT3 codes that came out last year in January that provided a reimbursement for broadly for AI ECG technologies for diagnosing cardiac dysfunction broadly. However, even though those reimbursement codes are available, the uptake has been pretty slow. There's not been a lot of uptake yet, so it's just taking time for reimbursement to come. And then those CPT3 codes need to be moved to Category 1, and so that's just going to take time. The second piece, I think, is really workflow integration. Part of the issue is we will come up with a tool to find patients or screen patients, but then how do we then action the information and then treat or get those patients into the system? So it's more than just the technology itself that finds the patients or monitors the patients. It's how do we deploy into the real world setting? So for instance, for aortic stenosis screening technology, we're looking at not just deploying this into a platform in a hospital system, into their electronic medical record system, where we find patients retrospectively and then just deluge the cardiology departments with all these screened patients. We're thinking about the broader solution deployment where we have people on the ground or platforms or processes that then take those patients and help move them along the process to ultimately get care. So it's not enough to just think about the algorithm, but you have to think about the system more broadly. The third is just something I alluded to in my last answer, and that's downstream capacity. So if you're finding all these patients and referring them into the system, you might overwhelm the specialist system. So you need to figure out how to drive out. You need to think about how you triage those patients and move them through the system. And again, even if you have a very high performing algorithm with a high sensitivity, if the prevalence of the condition is low, you could still have a high false positive rate or a low positive predictive value. So thinking through how you move those patients along needs to be thoughtful. You can't just take the signal from your algorithm. You need to take perhaps a holistic picture of the patient that says, this patient not only has a signal from our algorithm, but a few other things that make them high risk. that makes it more likely that they truly have the condition, so that you're really surfacing the patients that are truly the ones that need the follow-up the most. And you know, so those are a number of the ways in which adoption barriers are there, but with time and investment and thinking, we'll get over that, but it's just going to take a little bit of time.
Fantastic. And obviously, there's a lot of folks that have questions for you. We want to get those answered. We've got about a minute left, though. And so we can obviously, they can talk to you at the summit next week in Times Square, Microsoft Tech Center. What is it that you're most excited about for the summit next week? And what are you most excited to share when you're at the summit next week with the audience during your presentation, your paper?
Yeah, absolutely. So we have 2 FDA breakthrough device designated applications that we're really excited of, you know, to further this concept of ECG as a biomarker. One is that aortic stenosis detection algorithm. It's the very first AI ECG algorithm for aortic stenosis detection. We are excited to partner with pharmaceutical companies and device makers that have a focus on TAVR and aortic stenosis and structural heart. We have algorithms for broader structural heart as well, but we're focusing on aortic stenosis. The second is our breakthrough device designated and TAP designated hyperkalemia application. Again, we're looking at monitoring hyperkalemia as an adverse event and trying to better help clinicians treat the potassium and keep patients on guideline-directed medical therapy like RAS inhibitors, MRAs, aldosterone synthase inhibitors, keep patients on their therapy so that they have better all-cause mortality subsequently. So we're looking to partner with pharmaceutical companies and with KOLs that are looking to do pilots and research with us. We've done large retrospective studies. We've done a clinical pilot. We know that the technology works. Now we're trying to demonstrate value in managing these patients. And so we're looking for partners in this space, both on the research side and on the pharmaceutical side, to demonstrate value. So that's what we're most excited about, and I'm looking forward to participating at the summit next week.
That's great. Well, Moin, thank you so much for joining us today. Looking forward to seeing you at the summit, and enjoy the rest of your week. Take care.
Awesome. Thank you again.
So we've got just a lot of good digital technologies coming to the summit next week. Don't forget to sign up. One of those platforms that will be joining us is Dr. Lisa Fitzpatrick and Grapevine Health, also known as Dr. Lisa on the Street. You may know her from her videos. Lisa, good to see you. Thanks for joining us today.
Hi, Stan. How are you doing? It's good to be here.
I am doing well. And if you could, give everybody in the community a little bit of your background and what brought you to Grapevine Health, brought you to found Grapevine Health.
Well, I'm a physician. I've been a physician for a long time, over 20 years. And I spend a lot of time in community. And some of the things I hear from people are related to how they don't trust us in healthcare. We overprescribe, at least that's their perspective, and that we speak in a language people don't understand. So because we aren't addressing these concerns, we have a huge trust gap in healthcare. So I decided to use my skill to talk in plain language in the community. And I created a video series many years ago called Dr. Lisa on the Street. And the community receptivity was really positive. So fast forward 15 years later, here I am as the founder of Grapevine Health. And we have exploded the Dr. Lisa on the Street model with different types of doctors and different specialties to provide relatable health information from trusted messengers.
It's fantastic. And we all know that there is a lot of trust right now around the healthcare system that's been challenged. And when you take a look at some of those barriers and some of those challenges around building trust in the healthcare system, what are some of the biggest things that you're seeing driving that, particularly in underserved communities?
Well, in addition to not speaking the language people need to hear, we need to tailor our messages so that people understand how to engage in healthcare, feel comfortable asking questions, feel comfortable engaging in care. And I think that is overlooked. I think health literacy is an undervalued and under-recognized driver of cost, outcomes, patient satisfaction. So I think one of the biggest lessons I've learned on this journey is that it's foundational to ensure people understand health information, because you can't get them in the door if they don't trust you. And as someone told me when I was on the street, if I don't understand you, I don't trust you. The other thing I've learned, and I've worked in 4 or 5 health systems over my career, is that we need more humility when it comes to understanding the community. People are frustrated that we often ask for their feedback, but then we don't implement it. And then sometimes we don't ask for feedback at all. Now, I'll offer an example. One health system I worked at many years ago was run by a consulting firm because the hospital was close to being financially insolvent. And they sent out a letter to community members inviting people to come into the hospital to give feedback about the new direction of the hospital. And I think that is mistake one. We are expecting people to come to us when we should be going to them. It's really important for us to be in community, to see how people are living. What are their experiences like? What are their priorities? And why does healthcare seem as if it's at the bottom of the rung when it comes to priorities? And so I know health executives are very busy, having been one myself, but we can't afford to continue to ignore this. There's a chorus growing louder and louder and louder for us to address the trust deficit in healthcare. And I think it starts with listening and building trust, because people can tell when you're being genuine about whether or not you care to change the processes and the barriers for them to get the access to care they need.
No, I can't agree with you more, Lisa. I think you're spot on there. And I think one of the things we should really double click on is talking about those healthcare leaders that you're mentioning. How can those leaders, those same leaders, better meet patients where they are, where they live, where they work, not just structurally, but also culturally, so that those moments of engagement that you're talking about can improve the outcomes of the patients around all over the country, rural, suburban, urban, underserved, et cetera?
Well, I think first, I mentioned having humility about what we know and what we don't know, but that includes really openly listening to people and I'm hesitating a little bit, Stan, because I know that people know these things. I think we've had lots of conversations about the need to listen to community. So, but I want to encourage folks. It is very instructive to go into a community and talk to people and understand why medication adherence is low. Why is the no-show rate so high? Why are people using the emergency department instead of going to a primary care doctor? And once you have that information, acting on it. I think that's a huge problem across the health sector. And I already mentioned people are frustrated that we ask for their feedback and then we don't implement the feedback, because people will tell you why they're not adherent to medications if you ask them. Sometimes there's a cost issue. Sometimes there's a trust issue. Oftentimes there's a health literacy issue. We saw a woman a few years ago in the emergency department who misread her medication bottle because it said take twice a day, and she thought it meant take 2 pills at one time. And she bottomed out her blood pressure and ended up in the emergency room. So those are the kinds of things I think we really need to own and address if we really are serious about improving trust, decreasing our no-show rates in the clinics, linking people to primary care. And it's no secret, we have a primary care deficit right now. So what are some of the things we can do to improve access to primary care? And the final thing I'll say on this, Stan, is I think we have a lot of false narratives in healthcare. And one of them is that because of the digital divide, we can only reach certain people. But the truth is there's a wealth of research showing that almost everybody has at least a smartphone now. I think the latest Pew Research study showed that 96% of Americans have access to a smartphone. So the question is, how do we innovate for the technology people are using? Because even this can build trust because they see that we are trying our best to provide access in a way that's accessible and favorable to them.
Yeah, there's no doubt about it. And let's go back to what you said about listening. I just love that idea of we need to listen better. That's so spot on, and particularly in this day and age where there's so much misinformation going around. So let's dial that up a little bit. What role does this effort that you talk about, community-based listening, play in addressing the misinformation and help improving the public health understanding?
This is a really important issue, and I'm glad you're raising it. So the way we communicate often in research, in healthcare, anything scientific, we tend to create messages that are for us. It's a very insular conversation. We talk to each other. We're familiar with scientific and medical terms, and we become so accustomed to speaking in this manner that when we're talking to the public, we think they know what we're talking about, but we have lost them. And an example of this, because I just had a conversation this morning with someone who asked me, well, how do you tailor your content? Because someone may have a college education and they don't need the kind of education someone needs who has no high school diploma. And the truth is, health literacy impacts 90% of people in different ways. And so we forget that just because someone has a fancy education doesn't mean they understand how to navigate the healthcare system. So we have to partner with community members, with organizations. We have to ask people, how do you want to receive information? And once we have that information, we can use that to also marry that with demographic information. Is there something cultural here? Does it need to have a cultural lens? Does the messenger matter? Do Black patients want to hear from Black doctors? People who speak Spanish, do they want to hear from doctors who speak Spanish? This has been our experience. Yes. So I think there's some very low-hanging fruit here that I think, are largely ignoring because we feel it's too simplistic. And I'll close with an example from the street. So most people would say to me, including this person I talked to today, well, everybody knows what a colonoscopy is. We use that word a lot. It's a very common word. But I asked a woman if she knew what a colonoscopy was. And the way she described it, she was talking about a pap smear. So I think we take for granted people's level of proficiency and fluency with health information. And that's why what we do is so important.
I can't agree with you more. I am definitely on Team Lisa. So tell us a little bit more about how digital can become a mechanism for improving healthcare communications and reducing the divide.
Well, I think it's pretty obvious. We often overlook the obvious because it can't be that simple, can it? Where are people getting health information? Forget about health information. Where are people getting information, period? And we've asked lots of people this question as well. They're getting it from social media. They're getting it through the grapevine, from friends and family, from people who in their family or in their sphere of influence who've maybe been in the hospital. I had a woman tell me, well, we go to my uncle when we have a question because he spent almost 2 months in the hospital and he knows almost everything about healthcare. So he is the person they call when they have a question. They don't call a doctor. So I think using technology to reach people where they're already paying attention is kind of a no-brainer, Stan. The question is, why aren't we? We're afraid of text messaging, but people are using text messaging every day to communicate. I met a woman who was filling out a job application on her smartphone. So if that doesn't illustrate why we need to be innovating using the smartphone, I don't know what does.
100% agreed. And so now we got about a minute left, but if you could talk a little bit about what you're looking forward to about next week's HITLAB Summit and what insights you're most eager to learn, most eager to share with your fellow attendees at the summit next week.
I think maybe two things. One is the signals we've accumulated that suggest there's a connection, there's a strong connection between trust, engagement, and patient outcomes. So we spend a lot of time and energy focused on value-based care and how to improve engagement, but we don't address the trust piece, which is often linked to confusion, low health literacy, which are very basic issues we don't address. So I am looking forward to talking more about how we are accumulating evidence to show that these things matter. And the second one I've already alluded to, which is we really need to double down on innovating for smartphone usage. Because if you want to reach people in Appalachia or in underserved communities, inner cities who are historically distrustful of the healthcare system, the best way to start building trust is to create access with tools they're already using. So I'm looking forward to sort of beating that drum even more, Stan.
All right, outstanding. We want to hear more of the, we need more drum. We need more cowbell. Outstanding. Well, Dr. Lisa Ondestri, thank you for joining us today. We're looking forward to seeing you next week at the summit. And again, for anyone that wants to meet Dr. Lisa, don't forget to sign up for the summit next week, Tuesday, Wednesday, Thursday at the Times Square Microsoft Tech Center. Thank you, Lisa.
Thanks, Stan.
All right, and we are moving ahead to the last 30 minutes of the April Symposium and looking forward to handing it off to HITLAB's own Ansley Bowen, who'll be talking to the founder and the CEO of Soho MD. Ansley.
Thank you so much, Stan. And today I'm here with Dr. Jacques Jospitre, who is the co-founder and CEO of Soho MD. Thank you so much for your time today, and I would love if you could introduce yourself to our audience.
Hi, Ansley. Thank you for having me on today. So I'm Dr. Jacques Jospitre. I'm a psychiatrist with a background in business and tech, and as you mentioned, a co-founder and CEO of Soho MD.
Well, thank you again so much for your time today. And I would love to start off by asking you, how is Soho MD leveraging its care models to help improve outcomes at a population level, as well as particularly for underserved or high-risk communities?
Yeah, absolutely. So Soho MD, so it's a behavioral health practice. We initially started just focusing on high quality care, doing standard American Psychiatric Association guidelines. And over time, we found that patients weren't getting better as much as we wanted them to. So a typical response rate is like 30–40% when you use psych meds. And over time, we got into integrative health and functional medicine, and we saw that when we started combining nutrition and endocrinology, that our response rates went up significantly. So things that the typical psychiatrist would not be thinking about when it comes to psychiatric care, we started to incorporate, and we were finding all these unaddressed issues clinically with patients, and we started combining that with the psych treatment, and patients were doing really well. So when it comes to populations, a lot of times you find in underserved areas that people are getting medicated very heavily for conditions that could be related into psychosocial stressors or other nutrition or endocrine issues that are not identified or treated. And so with our care model, because we kind of dissect all these different pieces to give people a very robust treatment plan, we're thinking beyond just like, here's your pill and I'll see you next week. We're thinking about, these are the stressors that might be contributing to your presentation, but these are some nutritional and endocrine issues where we can send labs to get some very objective biological factors that are causing their psychiatric symptoms. And by doing that, we're dramatically able to increase the quality of care that those patients are receiving without having to increase the cost. The medications that they typically get prescribed can be very expensive. And so this intervention where we really think through in a very medical way, but very biological way about their psychiatric cases, it helps us identify very cost-effective strategies and approaches to get those patients better. So that's our approach and our contribution to the
Yeah,
population.
no, that sounds amazing too. And as you were kind of talking about that, that made me think about my next question about the specific strategies that you implement to help reduce disparities in mental health and behavioral health, kind of across that whole the spectrum there, and especially when it comes to like access. So, how are you measuring like progress in order to be able to advance health equity?
So it's a great question. In terms of seeing progress, the first thing is engagement. Just the
Mhm.
fact that the patients are able to come in, and we make that easy using telemedicine, so you don't have to have a job where you need to take an hour to
Right.
go across town to
Yeah.
see a provider. So how quickly you're able to see your provider, the ability to follow up. So you know that you're able to go to those ongoing sessions to continue your treatment. And also, we take standard rating scales at the beginning and then see your evolution in terms of the improvements of those rating scales. So, how bad were your symptoms when you first started your treatment? And then, how much does that improve over time? And so, by monitoring those factors, we're able to get some clear objective measures that things are getting better. And
Mhm.
even biologically, we track people. So, when we find biological factors that are off, we can see, you know, those initial rates. We can have an intervention where we're addressing those problems and then see those things get better. So, for example, if someone's low in B12, we would expect that we treated, you know, we've taken care of treating it, and the patient's levels get back to normal in the future. So, all those things are factors that we use to monitor that we're making progress with the patients.
Yeah, and just the fact that you also mentioned that, you have like a telehealth service available so people can have easier access and can talk with y'all instead of having to take time out of their day to go into a in-person place is great. And that makes me also wonder, like, do you have any collaborations like with either public health agencies or health systems or community organizations to be able to deliver that more coordinated and then also scalable care?
Yeah. So SoHoMD has been working on taking this clinical approach to care and
Mhm.
really building AI agents that help implement it, to help it both on the clinical side and the operational side. We're now working on projects to deploy this with health systems. So one of the things historically is we've really worked with commercial payers. So with health systems, you need to be in the public ones like Medicaid, Medicare. So we're adding those components to our roster. And so those are the projects that we have for the rest of this year and early next year is really taking this sort of partnership arrangement where we can take all the clinical work that we've done, and because we're able to leverage those AI agents, we can bring that quality and scalable care to systems to help give people more access to what we've been doing.
Well, that's great. And also what you were saying earlier kind of about that data, right? Where you want to make sure that you can monitor and make sure that people are either taking their medications or that they're improving and kind of how you can monitor that. What role does having that data really play in identifying gaps either in care across populations, or how does it translate as well into insights that are actually measurable improvements?
Yeah, I mean, the AI revolution has been a wonderful, wonderful time when it comes to understanding data and leveraging data in useful ways. So data
Mhm.
is definitely at the heart of everything that we're doing, both in understanding, where the problems are, what are the things that we need to address and fix, the places for improvements in terms of what, it points to, what interventions you should implement, and also being
Mhm.
able to track that whatever you're doing is working. So we see wonderful opportunities both on the operational side to decrease cost of delivering care, and even more exciting for us is on the clinical side that there's so much genomic data and other biological markers and lab tests that we can incorporate in terms of how we do psychiatric work. And
Mhm.
so we really see that we're at a point in the in the discipline of psychiatry where we can really have this transformation of how we think about mental health conditions, and both in terms of defining them and treating them. And data is what's making all that possible. So definitely a really exciting time to be leveraging it.
No, no, definitely. And I guess kind of a good wrap up question here would be kind of looking ahead, what innovations or partnerships would be most critical for expanding this access to behavioral health services at a scale while still being able to maintain that quality and equity that I know is very important?
Yeah, I would say there are two of them. The first would be on the biomarker side. So I think there are a lot of great minds working
Mhm.
on really helping to change how we think about medical conditions and psychiatric conditions. So partnering with people who are coming with those innovative solutions and incorporating those solutions into our platform. That's one real important area for us. And the other part is community, how to help kind of bring people together who are going through a patient journey together and really creating a forum where they can share their experiences and really get access to the best, just a wide range of solutions and some of the ideas that we think are best in terms of treating their conditions. So creating a forum for them to really take ownership of their clinical experience. That's also another important initiative for us. So
Yeah.
I'd say those are the two.
Well, amazing. And I also just wanted to let everybody know that you will also be at our summit that's going to be taking place next week, May 5th through the 7th at the Microsoft Tech Center in Times Square.
Yep.
So if anyone is interested in, purchasing a last minute ticket, or if you're already coming, you have a chance to be able to speak with Dr. Jacques here and can explore a little bit more about what the great work that he's doing at Soho MD. So thank you so much for your time today, and
Thank
look
you.
forward to seeing you in person next week.
Yeah, same here. Really looking forward to it.
Okay. Well, thank you so much, and I will hand it back over to Stan.
Outstanding. Once again, for any of you who want to follow Ansley's advice, here is the best place to click on and register for the summit. The link is in the chat box. Ansley's going to pop it in the chat box for you now, so you can go ahead and just do a quick link there. And you can also click on the QR code. In the meantime, we would like you guys to do another poll. And as you know, the adoption of digital technologies and the evidence therein is what we do every day at the lab. And we are not only evidencing technology solutions, but we are also aggregating evidence and helping people understand the tea leaves and what's being adopted and what's not, and why not, and how to better actually implement technology in various clinics, health plans, radiology centers, pharmacies, labs, life science companies, and certainly hospital systems. Anyway, we'd love to get your opinion on this. So if you don't mind, if you could pop in your answer for what you think the biggest barrier to digital technology is today in the world, and how we can get better at deploying this is really the primary concern here. If you have questions around that, absolutely hit the Q&A function in the Zoom here that we have today. And certainly we have a number of different answers. I'm sure there's dozens of answers, but these are the big ones. Certainly regulatory, integrational issues with legacy systems. The big one is lack of reimbursement models. We know that for sure. Data privacy and security concerns, that's always something that's front of mind when it comes to healthcare. And then general organizational resistance is another one. And then just the human resources that people need to deploy new technologies. Everyone these days is doing 3, 4, or 5 jobs at a time. And so who's going to take on the new shiny tool and implement that? There's very few people that raise their hands and want to volunteer for that kind of assignment. So we do know that human resources is certainly an issue around this as well. And so again, we will be writing up a paper on this and looking for your feedback if you're interested in writing with this. If you want to join in the authorship of the paper, shoot me a note on LinkedIn. You can find my LinkedIn in the chat, and happy to work with you on publishing out that piece of data. I think we have time for one more poll, and we're going to, actually, I'm getting a message. We're going to do the poll at the end after we talk to Leslie. So next up, I am thrilled to introduce everyone to Leslie Godkin, a Columbia Business School alumna and a founding partner with the company called Home Catalyst. And looking forward to hearing from Leslie today about this revolutionary real estate healthcare platform. Leslie, how are you and where are you?
Hi, Stan. Thank you. And good to see everybody here. I am in Minneapolis today, my hometown, but we'll be in New York next week. Very excited to see a lot of you also at the HITLAB event. And New York City was my home for 16 years, so very excited to come back.
Tell us a little bit about your journey in founding and developing Home Catalyst as a novel and revolutionary real estate healthcare platform.
Yeah, Great. Well, so our firm is looking to scale housing for adults with autism and disabilities in a way that we can do in every market throughout the United States. And I came to this after working in mostly real estate and healthcare, investing in the business world for about 15 years. So I was very fortunate to work in real estate investment banking. I worked, with a lot of large institutional real estate firms during my time in New York, and also for a large hedge fund, and then went to Medtronic, where I learned a whole different thing about use of data and AI and how to look at things through the lens of patient populations that are unserved. And I also looked at this through the lens of my own experience with my sister, Alex, who's was one of the first females to be diagnosed with autism in Minnesota in 1987. And she was my reason for moving back home initially. We had a lot of challenges with her situation, which goes into a much longer thing I could probably write a book about. But what I saw was really no solutions that were working, and families like myself picking up the pieces, and pretty much every family we knew that was picking up the pieces, despite financial resources or not. And I said, there's got to be a solution that we can create for someone like my sister, who's a quote unquote high functioning adult with autism, but who can't drive a car, manage a bank account, or, really take college courses unassisted. So she can be a great resident. She can be a great homeowner. She can live independently with supports. And yet she's not a priority, or hasn't historically been, in the housing ecosystem. And so after these events that happened in my family, I felt really inspired. I felt like this was truly what my life's mission was meant to be, was to solve this and take my finance and healthcare investing background and figure out how we could do this. So I'm really excited that, we formed the company almost 3 years ago. We've made several investments, and we've raised seed capital. We're now raising more, and our goal is to scale this throughout the country, and in a way that we can take it from, really 0 to 1, where it's a fully for-profit solution.
What a great story. First of all, Leslie, thank you for being so open and sharing about why you're doing this. And with such an impressive background, I know everyone's really excited to see this grow. What problem is Home Catalyst Partners trying to solve, and why is now the right time for this focus?
Yeah, great. I mean, so in terms of the total demand, we have about 13 million people in the United States with some form of autism or related intellectual developmental disability. About 80% are living with family in adulthood, and they are really categorically not being served at all in the housing ecosystem. There's less than 200,000 units of group homes in the country, and virtually every family in the country, does not prefer a group home for their family member because they really don't work, and they don't work long term. And so we said, look, the solutions out there really are group homes. There's no supply to really meet the amount of demand. 80% are living with family in adulthood. They are, 25% of healthcare costs effectively. Lots of them end up in the hospital ERs. They are 400% more likely to become homeless. There's estimates that about half the homeless population have some form of autism or related disability. So we're saying, this is a very large problem set that is not being served, and it's vast and it's growing, particularly because autism is growing. And there's ways that we can serve this population in existing housing assets that have basic quality standards that they need, such as, safe, walkable neighborhood, and community and fitness in the building, and affordable units. And we can do that in partnership with high-end, in basically, every major market throughout the United States has requirements for affordable units in luxury Class A and B multifamily assets. And so what we're doing is partnering with those developers and saying, or owners, and saying, you already have these required affordable units. They need these units. They should be prioritized for them. We're investing in a good real estate deal. We're an investor in the real estate, but we also understand how to make sure that this population has services in the property paid for with Medicaid, which many of them receive, and they receive those services in their parents' home. And so we understand the gestalt, I'll call it, of knowledge of the cross-section between finding good real estate investments and good markets, the fair housing laws, and the Medicaid and services laws, and how to put the pieces together and result in a great investment that we can do in every market, and also one that results in long-term housing for them.
Yeah, that's incredible. And this fundraising environment seems like one that's ready to get going and really back this. Talk a little bit about your fundraising strategy. What does it look like? What types of investors or partners are you currently looking to engage with?
Yeah. So the first, I'd say historically, the first 5 million into our first couple of deals was all high net worth, friends and family. We were very fortunate to bring in a lot of highly sophisticated people from real estate and healthcare and the financial world. A lot of them have a personal connection to this. And now we're bringing in our first institutional investor, the Pulte Family Foundation, to invest in our Michigan investment and potentially grow that. It's an ownership model that we'd like to grow and potentially grow with Pulte Homes parent company. And but yes, we are raising another couple million of seed capital into our company to grow our team. We're bringing on some incredible industry talent that has experience raising billions of dollars in real estate. And I'd say, people love our mission. So, we're also saying no margin, no mission. We're doing this in a fully for-profit way we can do everywhere. So people that want to be part of investing and supporting, a first mover in a category that has significant growth potential and protected IP insights and knowledge about how to do this while building a best-in-class housing company is, the right types of investors for us, whether it's a high net worth individual, a foundation, family office. We can also, because of our mission, bring in capital via DAF, Foundation and Charitable Donation Capital, by partnering with a firm called Impact Assets. And so, we have to be creative. Like it's a lot of it's networking. It's picking up the phone. It's helping people understand our vision and also, that we're truly solving a problem.
Yeah, such a great vision. And talk a little bit about, we'll talk about the vision later because we want to double click on that. But, sticking with the fundraising line of thought for a moment, what are some of the big milestones that a fund like yours looks at in developing its first few years of traction?
Yeah. So, I mean, if we had the couple million closed today that we're looking to close in the next month or so, my first goal is really get these individuals on board that we're currently negotiating agreements with it. And our structure for our fund, we're going to have a $150 million target for the fund. We've already been testing the waters meaningfully with a lot of different capital sources for the fund and deals themselves. And this is after years of working on this, right? Refining our model, refining our mousetrap. Now we have track record on our deals, which are performing incredibly well financially and operationally. And it's our ability to show people that we've done this, that we can do it everywhere. We have significant opportunity for pipeline that we've identified around the country and showing them we're building this team. And then in terms of, I think we see the first probably 50 million of investment in the fund will be a lot of high net worth people, foundations, and related investors that we've already been talking to, quite frankly. So and I could see probably the first, we also going to be targeting what are called joint venture or separately managed account relationships with pension funds and family offices. We're already speaking to a lot of those. So we have very large established, firms that we're speaking with that manage billions and billions of dollars that we're actively negotiating those types of agreements with. Some of them want to do deals in New York City and the New York area. And so part of our ability to expand those conversations and really, monetize them it'll be important that we build our team to do that. And I could see those relationships with those JVs or separately managed accounts being, typically they're 100 to 500 million in terms of the agreements, and those can take various forms. But there's so much demand for this housing, and our ability to source pipeline is not the challenge. And it's really building that team right now. And we've already got a lot of things in motion on the actual capital for the deals, as I said.
Incredible. And let's you mentioned the word partnerships, and that's always so powerful when it comes to the ability to accelerate growth. Talk to us a little bit about the types of strategic partnerships you're envisioning and how they're going to help accelerate your growth. And I think importantly, your impact, because what you're doing is going to have such an incredible impact on the US housing system, healthcare system, family system, right?
Yeah. Yeah, exactly. So my thesis the whole time was we can figure out a way that we can partner with the best-in-class multifamily housing companies and home builders throughout the United States. And so now we're starting to really establish those relationships in a more meaningful way. And our goal, kind of once we get a larger team on board here, is to really, we've already been talking with large publicly traded REITs and home builders about our models and about working with them. We know that some of them are already doing these types of set-asides in their existing assets, but they don't have as much special sauce and knowledge about how to do it as well as what we have done. They haven't spent as probably much time looking at this. They're more focused on their core business. And so, once what we've seen in the past is once we're able to get a few large housing companies on board, they all want to move in and they're very competitive amongst each other. And it's the same with the capital. Once they hear that like their competitor kind of private equity firm or family office is interested, then they want to do it too. And so I have to be honest. I mean, I think coming from working in banking, working in M&A, working in the deal kind of investing world, I understand the nature of building that sort of competitive dynamic where I think the more we're able to have a team in place that can generate competition and pipeline with and momentum with these capital relationships, that's really going to feed on itself because there'll be once, it's just the nature of kind of how deal making works. And so, and it's also turning the needle on its head and saying this does not have to be a nonprofit solution. These individuals deserve access to great housing just like you and I do, and they deserve it today. And I think how we're really going to solve a problem is not it's truly by making it, we're partnering with these large housing companies. They just don't know how to do this. They haven't heard of it. And that's why we pick up the phone, we educate, and we're, partnering with them to do this. And you're right, Stan, this is historically been something that families are really bearing the brunt of the challenges here. So the majority of them are, fortunately, I mean, the majority are not what you see with the Elon Musk. The majority, 99% are living, a more financially constrained existence, often can't drive or have the same full life, but they deserve a bigger life. And so do their families, quite frankly. So the family financial burden on average is to the tune of about $3.5 million over the course of the life to support these individuals. That's a combination of foregone income and out-of-pocket costs. And, the families are the ones keeping them out of the hospital. The families are the ones bearing the financial burden. And we see our total addressable market here is also the families, because they're the ones that are going to benefit through their loved one being in a better quality housing solution.
That's really an incredible story. Talk to us about your vision of Home Catalyst over the next 5 to 10 years. What's the future of Home Catalyst look like, and its impact on the American family and the overall American society?
Yeah, I mean, we see this growing to a multi-billion-dollar business. And I mean, if we're truly going to solve the housing needs for this population, the total housing costs are at least $1 trillion that we need to deploy and make this a priority in the housing ecosystem. If we can, we've deployed over like nearly $1 trillion in affordable housing in this country, and probably close to that in senior housing, and significantly more than that in multifamily. If we can solve senior housing, which 40 years ago, senior housing was nonprofits and families doing it themselves. That's exactly what you see with this today. And so if we can do that and turn it into an institutional quality solution, we can solve this as well. And I see this, we're a first mover. We have the knowledge, we have protected IP on what we're doing. And we're building that, using AI tools, using our knowledge, if you will, and going into these markets and growing this business. And these individuals deserve to be served, and their families deserve to be served. So I think this can lead to this entire focus also on really actually elimination of homelessness truly at a base level, because a lot of these individuals are being forced into homelessness because there's not a solution. And housing system right now focuses on taking homeless individuals and housing them. And it's like, let's move upstream and let's actually do things that work long term. So
amazing. So inspirational. What a great way to end the symposium the week before the summit. Don't forget, everybody, if you want to meet Leslie and hear more about what she's doing, if you want to join her team, meet her at the HITLAB Summit. If you can't join the summit, her LinkedIn link is in the chat box. Connect with her, help her out. Let's help out folks who have adult children with developmental delays and disabilities. Leslie, thank you so much for joining us today.
yeah, thank you, Stan.
Incredibly inspirational, everybody. And that's more from the HITLAB. That's what we love doing, the kind of work that we do here. And that wraps up the April episode of the HITLAB Digital Health Symposium. And thanks again to an amazing HITLAB team that puts these on for you all each month. Rachel, Ansley, Raymond, Pallavi, Melissa, Jerry, Nico, and Rijo. Thank you all. You guys are an amazing team. I love working with you every month. And thanks to our amazing sponsors. These are the folks that bring this to you for free. So everything from the Merck Global Health Innovation Fund to Microsoft, DLA Piper, Information Mediary, Fin Partners, Nagaro, and Actual Health Solutions. They are the ones that make this tick. In the meantime, enjoy the rest of April. You've got about 12 hours left, actually 10, and I hope to see you all at the summit. If not, we will see you next month on the May Digital Health Symposium. Everybody have a great rest of your day, and we'll talk to you later. Take good care.